Honorable guest of honor, the Deputy Permanent Secretary, Science, Technology and Innovation, representing the Minister for Education, Science and Technology, Professor Adolf Mkenda, the Acting Vice Chancellor, Muhimbili University of Health and Allied Sciences, the Acting Deputy Vice Chancellor, responsible for academic, Muhimbili University, the Director General, National Institute for Medical Research, the Deputy Vice Chancellor responsible for research and consultants, MUHAS, the representative from the Swedish Embassy and the coordinator for SIDA, Chairman of the organizing committee of the 11th MUHAS Scientific Conference, delegates from Ministry of Education, Ministry of Health, P.O. Raj, Deputy Vice Chancellor, Planning, Finance, Administration, directors, deans, delegates from sister institutions, faculty, students, MUHAS community, media representative, invited guests, a very good morning to you. My role this morning is very simple, but to invite responsible people from the high table to address this audience. May I start by inviting the Deputy Vice Chancellor responsible for research and consultancy to introduce the members on the high table so that we are all familiar of who is with us this morning. And immediately after he has done so, I will request him also to invite the chairperson of the organizing conference for welcome remarks. You're welcome, sir.
Thank you very much. Good morning, everyone. Jamhuri ya Muungano wa Tanzania. Thank you very much. May I take this opportunity to thank you all for coming. But I've given a very short task to introduce the high table, and after that to invite the chair of the conference so that he can give us the opening remarks. Ndugu washiriki, my colleagues, fellow scientists, we have a privilege today to have the Minister of Education, Science and Technology, Honorable Adolf Mkenda, represented by the Deputy Permanent Secretary, Education, Science and Technology, Professor Mdoe. Professor Mdoe has been with us in many occasions, and we thank him for taking time again to come at our university to grace this very congregation, but also represent or welcome Professor Mdoe on behalf of the Minister of Education, Professor Adolf Mkenda. Ladies and gentlemen, we also have our host at the university, who is the Acting Vice Chancellor, Professor Apolinari Kamuhabwa. You all know Professor Kamuhabwa and the work that he has done for the university, and we thank him for again having this conference happening at MUHAS again for 11th time this year. We thank Professor Kamuhabwa for the good work that he has done. But also we have our colleague, also our teacher, who is now the Director General of the National Institute of Medical Research, Professor Saidi Aboud, who is here with us today in his new capacity representing all the research institutions in the country. And we welcome you back home, Professor, and we hope that you will stay with us for the 2 days, learning together again and sharing experiences. In the high table also, we have the Acting Deputy Vice Chancellor responsible for academics, Professor Emmanuel Balandia. Professor Emmanuel Balandia is representing the entire academic portfolio of the university, and we also thank you for finding time to grace us in this occasion. And we also expect to learn a lot from you and continue to work with you on that. In the high table also, we have the representation of the Swedish Embassy, and especially recognize Ms. Eva. Ms. Eva is representing the ambassador of the Swedish Embassy, and in a special way, because through the support of the Swedish government, MUHAS has been able to do all these 11 scientific conferences, and it's a privilege as an institution to have such long-term partner. For now 40 years we have been receiving the support, and may we thank you on behalf of the university, and we hope that you'll convey our gratitude to the Honorable Ambassador on behalf of the Swedish people, Swedish government. Ladies and gentlemen, this conference has been organized under the leadership or the stewardship of our chair, the chair of the conference organizing committee, and who is Professor Simba, our teacher, our mentor, and also our leader in many aspects that we have gone through. We thank you, Professor, for the good work. And now, having that, yes, I was reminded, not in the high table, but was supposed to be in the high table because of the chairs, but may I also recognize the presence of the Deputy Vice Chancellor responsible for planning, finance and administration, because they only see you, the backside of your head. You can just stand and wave so that they know you. Thank you. That's our Deputy Vice Chancellor, PFA. We also have the Executive Director, Ocean Road Cancer Institute, not yet in the room, perhaps still in the poster, Dr. Julius Moiselage, and the delegate that he has come with. May I also recognize the presence of the PORAJ, represented here today by Dr. Tumaini. Just stand up and wave. And collaborators that we have in the room, just in groups quickly, the delegates from Japan, Kumamoto University, just wave and we see you and recognize you. And colleagues whom are working together in D43 grants, NIH grants, if you're already in the room, can just wave. Yeah, they're not yet here. We also, I see Dr. Angelekela, not yet here. So, yeah, thank you very much for this. And may I now pass this mic to, did I forget Minister of Health? Yes, Minister of Health. May I recognize the presence of our colleague, Dr. Bundala, representing the Ministry of Health. Just wave. Thank you. Now, may I take this mic back to the chair of organizing committee, Professor Simba, for the other proceedings. Thank you very much.
Thank you very much. As the speakers have said, they already have said, we have the guest of honor today, Professor James Mdoe from the Ministry of Education, representing the Minister for Education. Let me take this opportunity to welcome you all to this very important scientific conference that we have been holding almost each year without stopping And I think for this we need to congratulate the management of MUHAS for being able to do this for all the 11 years without failing. The theme for this meeting, as you all have seen in the abstracts that have been circulated to you, is the role of scientific evidence and innovation in enhancing resilient health systems in addressing global health challenges. And since I'm welcoming you to this workshop, I would want to take a little bit of time to tell you exactly why this theme was chosen. One, because we need evidence. You all will agree with me that in every day-to-day issues that we deal with in our offices, in the country, we need evidence. And if you need evidence, hard evidence can only be obtained through scientific processes. And this is what actually underscored our theme this year. Second is the whole issue of innovation. Universities are think tanks. Think tanks in the sense that we have time, we have opportunity, and we have support internally and externally to do research, good research. So this is the place where innovations in science should come out. And we at MUHAS are given the responsibility on the health sector. So the country depends on us when it comes to coming up with innovations in health. And surely we are going to hear in this conference some of these innovations. And lastly, but not least, is the whole issue of trying to address our environment. We are being challenged with a number of health problems, as you all have heard about Marburg, which we were able to wipe it out. These are challenges that are facing the health sector, and we need to address them. And when we address them, we should do it fast, and they should not compromise our health systems. And that's what we call resilience. So we are going to hear during this conference about how resilient is our health system when it comes to addressing these global challenges. So without taking much time, Mr. MC, let me tell you that this will be a 2-day conference. And I don't want to repeat about the participants that we have invited. As you have been introduced, we have participants from internal, meaning from within MUHAS, MUHAS family, from within the country, and from outside the country. So we have some kind of potpourri of participation. And I also would like to introduce you to the environment here, in the sense that in here we will be doing our plenary sessions. We will have satellite sessions on which you will be directed by ushers that we have plenty in this conference. So feel free to ask them. You will find them well dressed in attire that looks alike. Can one of you stand up so that they see how you, yeah. So in any case you have a question or a challenge, please see them and they will direct you. Having introduced you to this, let me again take this opportunity to thank the guest of honor and all the dignitaries and the scientists for coming and attending this workshop. Thank you very much.
Thank you very much. Thank you very much, the Chair. Allow me to invite the Swedish Embassy representative to give some remarks before I invite the Acting Vice Chancellor, who will also invite the guest of honor.
Asante sana, hamjambo. Honorable Minister of Education, Science and Technology, represented by the Deputy Permanent Secretary, Professor James Ndohe, MUHAS Acting Vice Chancellor, Professor Apollonary Kamuhabwa, researchers, members of staff, students, invited guests, ladies and gentlemen, all protocol observed. It's a true honor to be invited to participate in the opening of such a celebration of science, as is this 11th MUHAS conference. Sweden has given support all the way. And together with MUHAS, we are working on a new 6-year phase of support. I arrived here in August last year, and I'm charged to manage the research cooperation portfolio in Tanzania. It's a great privilege for me to have the backing of Sweden to contribute to continue assisting MUHAS University to develop and strengthen its research capacity. And we are very grateful that the Tanzanian government and people have put your trust in Sweden to work on this. And yes, global public health challenges is a theme. And the expectations that research, education, and innovation shall contribute to sustainable solutions to global and local challenges are high. This leads to increasing demands on countries to develop research that can attract international collaboration and at the same time increase its competitiveness globally. It is important for any country to invest in research and innovation for its future development as well as for the common global goals. Coming to Tanzania, MUHAS and health. The Swedish Research Research Cooperation in Health started already in 1986 with the support to a project on HIV/AIDS, and was later followed by reproductive and child health, malaria, and health systems research, all areas that are critical to Tanzania. I would like to commend MUHAS to have been ranked as the first university in Tanzania. In terms of quality research, and 5th in the East and Central Africa. And it's the 8th university in Africa based on the recent statistics. I think this is something to say, hongera sana. Equally and even more important is the influence that the MUHAS research has had on national policy. I'm not going to say all, but you know how important it has been. And this is when research really makes sense, when it benefits the whole society. Now, despite the successful results, there are challenges. Viruses, parasites, and bacteria They have a strong will to survive and outsmart us, which you already know, all of you, and that you are addressing at this very conference. The Swedish Research Corporation was set up to bridge the knowledge gap. And after 47 years of working with Tanzania in the area of research, we see many improvements in the indicators of research capability. Academic sustainability is increasing. The number of PhD holders, PhD programs that are established and accredited in supported areas, scientific publications continue to increase year by year. And there is institutional sustainability, which is very important. The structures for research, postgraduate training, and innovation are established. Policies and regulation for research, postgraduate education, and innovation are developed and implemented. And time-efficient management of calls for funds for research and innovation. And quality assurance mechanisms for master's education and doctoral education are in place and implemented. There is sustainable research environment. Relevant laboratories are established and maintained. A research culture and environment that is conducive to research is something that we have to continue working on, all of us. And, but there is also some financial sustainability. National funds are allocated for research and innovation. Funds are available for postgraduate studies, and external grants are increasing. And I wouldn't be Swedish if I wouldn't say something about gender equality, and I will. I think that health research is an excellent opportunity to apply the gender lens. And I see here in the posters that you do. I mean, you do research on themes that are important for women. And also for men, of course. And, you are improving on participation, although more can be done. And I just want to say that in the innovation, that's also a theme for this. This is worldwide. We have to recognize that women have transformed the way we do many things. The way we shop online is women. And we have revolutionized the lives of disabled people, and we have put the climate crisis at the top of the agenda. Our own Greta Thunberg. Despite these successes, female researchers and innovators struggled and get ignored in an economy built for men. And I think in a time of crisis as we have now, the ingenuity and intelligence of women and men is the very thing that can save us. And this conference gives an opportunity to stimulate a more vibrant research environment, to connect researchers and policymakers, and to bring students on board. I would say to all of us that we should enjoy these opportunities over the coming 2 days, and thank you very much.
Thank you very much. Another round of applause. May I now take this very special opportunity to invite the Acting Vice Chancellor of Muhimbili University of Health and Allied Sciences, Professor Apollinarika Muhabwa, who not only will give the opening remarks, but also will invite the high table to march forward for giving special awards before the guest of honor is giving the opening speech. Karibu.
The guest of honor, Professor James Mdoe, who is representing the Minister of Education, Science and Technology, Eva Holson, the Council Advisor on Research from the Swedish Embassy in Tanzania, the Director General of National Institute for Medical Research, Professor Said Aboud, We have the Acting Deputy Vice Chancellor responsible for academic at MUHAS, Professor Balandia, the Deputy Vice Chancellor responsible for planning, finance and administration, Professor Erasto Mbugi, the Deputy Vice Chancellor responsible for research and consultants, Professor Bruno Sunguya. We have the representative from the Ministry of Health, the representative from ProRaj. We have the Executive Director from Ocean Road Cancer Institute, representative from our partner institutions, especially the Muhimbili National Hospital, Jakaya Kikwete Cardiac Institute, MOI, and other collaborating institutions. The heads of government and the other institutions, the chairman of the 11th MUHAS Scientific Conference, Professor Daudi Simba, all government officials who are present here today, distinguished guests, our representative from the media, academicians, scientists, students, ladies and gentlemen, good morning. So on behalf of the faculty of community of MUHAS, including faculty, scientists, administrative and technical staff, and our collaborators, as well as students from MUHAS, and on my own behalf, let me take this opportunity to extend our welcome to the guest of honor, Professor Mdoe, who is representing the Minister of Education, Science and Technology for joining us today. We are all delighted and grateful and honored to have all of you here at MUHAS and online, those who are following online, for this 11th MUHAS Scientific Conference. Karibuni sana. So please allow me to convey our special appreciation to the guest of honor, the Minister of Education, Science and Technology, for accepting our invitation and sparing your valuable time to come and officiate the opening of the 11th MUHAS Scientific Conference. Thank you very much, na karibu MUHAS. Guests of honor, ladies and gentlemen, MUHAS, through support from the government and community partners, including the government of Sweden, has continued to grow and expand teaching and research environment while taking a leading role in providing consulting services, advice to the government, non-government organizations, as well as the international community. May I take this opportunity to thank the government of the United Republic of Tanzania for the immense support that has been provided to MUHAS that has enabled this institution to implement this mandate, including the conference that we are attending today. And it is through this support that MUHAS has continued to shine nationally and internationally. And for this, we thank the government and our development partners. Guests of honor, ladies and gentlemen, this year we are celebrating 6 years since the establishment of this institution. It started in 1963. It started at the Dar es Salaam School of Medicine, and in the 60 years period, this institution has grown in all areas, including the increasing number of student enrollment, undergraduate and postgraduate programs, researches, and publication in local international journals. And as the oldest university of earth and earth science in Tanzania, we are very proud of the progress achieved, especially in the field of training and research. And this has been made possible by MUHAS faculty, staff, students, our collaborators, and the government. All through the years, MUHAS has continued to be a reliable national hub for research output, supporting policies and guidelines, and supporting other institutions in the country. There are a number of policies and guidelines in this country that have been contributed by the research findings that have been conducted by MUHAS and its collaborators. And to date, MUHAS has over 135 ongoing sponsored research projects, which are working in more than 100 international and local collaborating institutions. This is the highest number we have ever achieved, 135 ongoing research projects. And in total, per year now, we have between 450 and 500 scientific papers in reputable, reviewed local and international journals each year. As an outcome of this research outputs, MUHAS has been ascended the ladder of universities to the best university in East and Central Africa. And we have taken the 5th position in the world of African continent. And this is the first time MUHAS has done so. And this success has been a result of efforts by MUHAS scientists, faculty, students, and our collaborating partners, including the Swedish government and Swedish people. And we believe that with the further dedication and support, MUHAS can do better than that. Guests of honor, ladies and gentlemen, we know that we are now moving towards a next generation university where innovations and research linkage with industries and commercialization is very crucial to our outputs that match the current needs. To keep pace with this, MUHAS has taken the initiative to develop an industry advisory committee through the Higher Education for Economic Transformation, that's the EAT project. And this is composed of experienced stakeholders from all areas of that MUHAS as regards as the consumers of our training and research output. So we have this advisory committee, and the members of this committee, we believe they represent the consumers, the consumers of our product, including our graduates and research output. So it is through actively engaging with this committee, the government and the collaborators, MUHAS believes that we can continue to flourish. Furthermore, MUHAS envisions an environment that supports innovation in earth and technology, and this has led to a creation of a special innovation incubation unit in the Directorate of Research, Publication, and Innovation at MUHAS. It is our hope that with adequate support, together with the research and development, that is R&D units in our schools and the institute, MUHAS will even widen its role in feeding the earth industry and beyond in our country. Guests of honor, ladies and gentlemen, MUHAS continue to grow and expand physical teaching and research environment. And the realization of the dream to have a centers of excellence in the areas of global and local importance is very important. That's to mention phase 1 of the construction of the East African Center of Excellence in Cardiovascular Sciences at Kansala Campus. It has been completed and it is in use. And now we have started the plans to establish phase 2 of the project, and this is the construction of the cardiac hospital adjacent to the building for Center of Excellence in Cardiovascular Sciences. Plans have started, we have the government support, and the committee has been formulated, start writing the proposal, and we expect we'll get funding for this phase 2, because we believe with the cardiac hospital, the center will be able to provide the required services that are designed to serve. So we, MUHAS, shall continue to work with the development partners, with the government, to make sure that more centers of excellence are established at the Mloganzira campus. Through the Higher Education for Economic Transformation project, in which MUHAS is a beneficiary, we are constructing the College of Medicine and other teaching facilities at Mloganzira campus. This will not only strengthen the university's capacity to perform its core function of training, research and services, but also shall address the nation's need that will continue to change owing to the changes in the disease landscape, health, and the developmental needs. We have many other plans in various stages of realization, and through MUHAS researchers, this will be realized. Guests of honor, ladies and gentlemen, please allow me now to highlight, without preempting the upcoming discussion, on our theme this year, which is the role of scientific evidence and innovation in enhancing resilience health systems in addressing global public health challenges. Recently, our health system have experienced shocks, and we are aware of the COVID pandemic. So this pandemic and the changing dynamic of non-common diseases are a few examples to mention here that we need to conduct more research and produce evidence to address these challenges. And it's high time that we learn and come up with ways to enhance the resilience of our health systems to both foreseeable and unforeseeable shocks. And MUHAS, as a leading health research institution in Tanzania, we ought to provide solutions, and this very important 11th MUHAS Scientific Conference is dedicated to that. On behalf of MUHAS, on my own behalf, I cordially invite you, your highly esteemed contribution, which I believe will aggregate into the needed solution in this regard. Guests of honor, ladies and gentlemen, as a training institution for Earth Human Resource, we are very grateful to the government of the United Republic of Tanzania for creating an enabling environment which has been critical in forging collaboration with our partners. This example is the Swedish government. May I also take this opportunity to thank all partners. As I have mentioned earlier, currently we have a number of sponsored projects, and these are supported by different partners. So we thank the partners, collaborators, funding agents, as well as local international organizations and institutions for the support that you have given to us that has contributed immensely to building research capacity and the generation of research results to inform policy in this country. And let me say, guests of honor, ladies and gentlemen, that I will not be grateful if I won't mention the Swedish International Development Agency, SIDA, again. As we have heard from the presenter from the Swedish Embassy, SIDA, for this matter, and the people of Sweden have heavily invested to improve the human resource and research capacity for MUHAS. And through this support, majority of highly trained scientists at MUHAS are the direct beneficiaries, while the rest are either indirect beneficiaries or implementers of the project that are supported by SIDA. Indeed, SIDA funding has significantly supported the growth of human resource workforce and output at MUHAS. Thank you very much, SIDA, and please convey our gratitude. Guests of honor, ladies and gentlemen, before I conclude my remark, let me again express our heartfelt gratitude to the government of Sweden again, that SIDA has been the main sponsor of our conferences for all these 11 years consecutively. And through these conferences, impactful research dissemination has been made possible through the conference like this, research-wide symposia. We have developed a number of policy briefs, national dialogues have been conducted, round-table discussion, and also we have disseminated our research finding through publication in reputable international journals. So once again, we thank the Swedish institutions, particularly the collaborating universities, for their support. And to mention a few, we have worked with the Umeå University, Uppsala University, Karolinska University, and Lund University in Sweden. Indeed, we thank the Embassy of Sweden in Tanzania, all the ambassadors who have served through these years of collaboration, and the SIDA coordinators for the guidance and the support. And it's my sincere hope that Sweden will continue to collaborate with us, particularly in the development of the much needed research infrastructure that will contribute to the sustainability of the investment in human resource development so far and the research output. Let me also sincerely thank the MUHAS faculty, scientists, support staff, and the students for having conducted research and made this conference a reality. My special thanks to the Directors of Research and Publication and Innovation and the organizing committee for this conference for your tireless efforts that have made the 11th MUHAS Scientific Conference a reality. I say thank you very much all for your efforts and time. So, ladies and gentlemen, let me now invite the guest of honor, Professor James Mdoe, who is representing the Minister for Education, Science and Technology, to officially open this 11th Scientific Conference. Yes, I'm told we have one more event before I invite the guest of honor, the special awards. Yeah, we have some awards for some individuals who have worked very, very hard in support of these conferences. And they have worked in different capacities. And I think it's important that you recognize these individuals. Some of them are the sleepless nights. They have sacrificed their time, their energy, and in a way, their career development. But they have done this for a good cause. The conference at MUHAS, this one, are normally organized by the Director of Research and Publication. But it takes an individual effort to have such productive conferences. So the guest of honor, for the past, I think, 5 or 4 years, we had a contribution of one member of our staff that he has worked very, very hard in organizing this conference. And we thought he needed to be recognized. And this is Professor Bruno Sungwe. So as you have seen, guests of honor, these conferences are normally organized through committees, and these committees normally have leadership. To organize such a conference, you need good leadership. And one of our senior staff that for many years has been the chairman of these committees is Professor Meksedek Leshabari. So, so the chairman of the current chairman of scientific will receive this award on his behalf. So, I think we are done with the awards. Yeah, so let me now invite the guest of honor to give his remark and officially open the 11th MUHAS Scientific Conference.
Ladies and gentlemen, I hope you won't mind if I address you while seated, yeah? Professor Apolinari Kamuhabwa, Acting Vice Chancellor, Muhimbili University of Health and Allied Sciences, Madam Eva Holsup, Counselor Advisor on Research, who is also representing the Ambassador of Sweden to Tanzania, Professor Bruno Focus Sunguya, the Acting Deputy Vice Chancellor, Research and Consultants, Professor Erasto Mbugi, the Deputy Vice Chancellor, Planning, Finance and Administration, Professor Emmanuel Balandia, the Deputy Vice Chancellor responsible for academics, Professor Daudi Simba, the chairperson of the organizing committee, Professor Said Aboud, Director General of NIMRI, representatives from the Ministry of Health and the Ministry of, the President's Office, or rather PRAG, representatives from Muhimbili National Hospital, MOI, JKCI, Dr. Julius Mwaisalage, the Executive Director, ORCI, Vice Chancellors, Deputy Vice Chancellors, principals from other universities and colleges, heads of development missions and development partners here present, heads of government and other institutions, distinguished delegates, academicians, scientists, conference organizers, students, representatives from the media, ladies and gentlemen, good morning. Jamhuri ya Muungano wa Tanzania. From the onset, let me start by registering an apology from the Minister of Education, Science and Technology, Professor Adolf Faustin Kenda, who was supposed to be the guest of honor in this occasion. However, due to other national commitments, he couldn't attend. And he decided to send me here to represent him, and I gladly took the opportunity, because as I always say, I belong to this kind of community, and I'm always happy to be here with you. Now, he gave me a speech to read to you, so I will read it verbatim. Ladies and gentlemen, let me take this opportunity to thank the management of Muhimbili University of Health and Allied Sciences for inviting me to officiate this very important 11th MUHAS Scientific Conference. Indeed, I feel greatly honored for this magnanimous opportunity of addressing this gathering of scholars, researchers, policymakers and implementers, and development partners in the field of health who are coming from inside and outside the country. For those coming from outside the country, let me take this opportunity to welcome them to Tanzania. Tanzania is a very peaceful country, and it's a very exciting place to work. So my hope is that you will have an enjoyment of Tanzania, as well as the hospitality of our people. Ladies and gentlemen, first and foremost, I would like to extend my heartfelt congratulations to MUHAS for marking 60 years of existence since her establishment in 1963, only 2 years after the country's independence. I'm pleased to say that the growth of MUHAS, particularly in health research and innovation, are among the significant achievements the country has seen in the health sector. I'm particularly pleased by the significant contributions this institution has made towards improving the health and lives of Tanzanians through training of highly qualified human resources, providing quality public service in health issues, and conducting research that is responsive to the needs of the country and the society at large. The Tanzanian government and the people of Tanzania applaud the journey you have undertaken and the achievements you have made so far. Ladies and gentlemen, I'm aware that this conference has brought together a diverse of representatives, including scholars, scientists, academicians, development partners, policymakers, and other stakeholders representing different sectors and subsectors related to health, higher education, research and development from within and outside the country. The continued participation of these delegates year after year signifies the relevance of these conferences to stakeholders in health and higher education. As the government, we understand the importance of scientists coming together to discuss, share, and exchange scientific knowledge that will eventually improve the health status of our society to foster the nation's socio-economic development. Scientific knowledge exchange in this kind of gathering helps us in the government in many folds, including to improve guidelines for the management of our patients, to develop preventive measures against diseases, and to help ameliorate suffering for those who get sick. Such discussions and presentations also help us as policymakers to interact with you scientists and share common challenges that require your scientific skills to address. Sharing such evidence from Tanzania with the global community also helps to put our country on the scientific roadmap, learn from others, and adopt the best practices for improving our work. Ladies and gentlemen, locally and globally, our health system continues to be challenged in several dimensions. The occurrence of pandemics and the change in population and disease patterns in our settings altogether pose major shocks to our health system. However, I'm pleased to learn that this conference aims to appraise the role of scientific evidence and innovations in making our health system resilient to these shocks. I truly commend the organizers for choosing a very pertinent theme: the role of scientific evidence and innovation in enhancing resilient health systems in addressing global public health challenges. I find the theme to be quite befitting because, as a country, we seek to foster the resilience of our health system to both foreseeable and unforeseeable shocks. It is my hope that through this conference, innovative solutions to increasing the resilience of our health system will be discussed thoroughly. Ladies and gentlemen, I've also learned that the 11th MUHAS Scientific Conference will also give its due attention to research that explore how best to improve our healthcare financing, taking into consideration the ever-growing healthcare costs that have been exaggerated by the recent health challenges, including pandemics, shifting populations, and changes in disease patterns. As a government, we are pleased to learn that during this conference, a multitude of presentations will be made around these hurdles, focusing on both increasing the level of understanding of the current situation as well as sharing of innovative solutions, as I said before. We are eagerly awaiting for the outcome of your discussion in this area, as it is one of the bottlenecks in the health services provision to our society. Ladies and gentlemen, it is well noted that there can never be a true economic development without good health, and that in order to improve health, we need health research. I've noted that this conference also covers other challenges in our health system, including maternal and child health, emergency medicine services, non-communicable diseases, health aging, antimicrobial resistance, and climate change. Some of these challenges have existed for the lifetime of our healthcare system, and some are emerging conditions. Nevertheless, they all strain our health system and need adequate attention from all angles. Therefore, it is my conviction that this conference will aid to the needed solutions to these challenges. Ladies and gentlemen, I've learned that within the framework of your conference, scientific outputs will be presented and discussed around 8 relevant sub-themes, which are 1, maternal, newborn, child, and adolescent health. 2, communicable diseases and antimicrobial resistance plus One Health. 3, non-communicable diseases, epidemiology and interventions. 4, nutrition, traditional or alternative medicines. 5, technology, innovation, and entrepreneurship in health. 6, health systems, that's policy, information, and financing. 7, surgery and trauma. And 8, climate change, imaging and re-imaging diseases. I urge all participants to take every sub-theme importantly, since the discussions and the lessons emanating from such sub-themes, from each sub-theme, will be concretized to obtain the highly needed solutions to the question, how better can we increase the resilience of our health system to both foreseeable and unforeseeable challenges? We need to answer this question. Ladies and gentlemen, the government has made several efforts and has put into place a number of initiatives geared towards supporting and creating a conducive environment for research and for building a critical mass of skilled workforce for research and innovation in the education and health sectors. Some initiatives have been mentioned by the acting Vice Chancellor in his opening remarks, but I would like to touch a few of them. One is, for example, the government has established a Research Excellence Award for researchers in higher learning institutions, publishing in high impact factor journals, in which case each researcher or for researchers, each researcher or researchers, as the case may be, will receive a sum of 50 million Tanzanian shillings for each winning publication. And this will start from this financial year, where the government has set aside 1 billion Tanzanian shillings for the initiative. I understand that researchers have applied for this already, and the team responsible for choosing the winner is working right now, so we shall come up with the winners in a few days to come. I believe some of them will come from this particular gathering that's here. But in order to come up with good researchers, good scientists, the government has also established what you call Samia Scholarship. And this is for the best performing from 6 levers in science, technology, engineering, mathematics, and health-related subjects. So this scholarship is for undergraduate students. It's for the time being, about 640 students have already benefited. It just started this financial year, so this academic year. So the coming academic year will be the second year. The aim is to reward the best brains in the country, so that at least you can nurture them, and then at a later stage they will become scientists of this caliber, and one day they will be here presenting their findings and finding solutions to our problems. So that's one of, that's another initiative. But you have heard also of the project known as Higher Education for Economic Transformation, popularly known as HET. Muhimbili University of Health and Allied Sciences is one of the beneficiaries of this, whereby $45.5 million have been set aside in a period of 5 years from 2021 to put in place facilities for training, for research, but also coming up with what we call, or rather establishing of data repository, updating curricula, and introducing innovative and pedagogical methodologies, training of academic staff, etc., etc. Overall, all these are aimed at, at facilitating the research and training environment. So this is, again, one of the initiatives. But you have heard also of the East African Center of Excellence in Cardiovascular Sciences at Mloganzila, whereby the centers, the building for the center has already been completed. But we are looking for money in order to construct also a cardiac hospital that will be used for research and things like that, and training. So the government is doing a lot. So what I've mentioned, these are just a few initiatives. I'm sure you will agree with me that the underlying efforts and initiatives will have remarkable contribution to the upgrading, the upscaling of research and innovations at MUHAS and the country at large. Nevertheless, let me reiterate that due to financial constraints, it has not been possible to adequately support research and innovation at the desirable level. As such, the government will continue to support MUHAS in its research and health service delivery endeavors within the available budgetary limits. As a government, we always appreciate that our development partners have always been with us throughout in addressing our resource challenges. And I therefore would like to take this opportunity to extend our sincere thanks to them for their support. I trust that it is through this kind of support that MUHAS has excelled in research. In that case, we still count on them as our partners in the future of MUHAS. Of special importance, however, I would like to convey our special gratitude to the people of Sweden through SIDA for their continued contribution to research over the years, and by being the main sponsor of this conference for 11 consecutive years. It is my sincere hope that Sweden will continue to collaborate with us, particularly in the development of the much needed research capacity, human resource and infrastructure to ensure that the efforts are sustained. The strong partnership that has been funded by SIDA has truly led to improved research infrastructure and capacity, and the results we enjoy today are largely attributed to their kindness, or rather to the kindness of the Swedish people. We thank them very much. Because we have Madam Eva with us here, please convey our appreciations to the people of Sweden. Let me also extend my sincere gratitude to other funders of MUHAS research, including NIH, USAID, CDC, DANIDA, NORAD, among others, and the research collaborators, including the universities, research institutions, implementing partners, international and local organizations, among others, who have provided commendable and valuable support to the many research and capacity building activities. On behalf of the government of the United Republic of Tanzania, I say thank you very much for your support and friendship. Asanteni sana. Ladies and gentlemen, may I take this opportunity to thank all researchers who will be presenting their research findings and innovations in this conference, because without them, there could be no conference. Since this conference is an annual event, future success will depend on substantial research outputs to sustain the conferences. It is my sincere hope that you will continue to do research with more vigor, energy, and diligence, so that your findings will be a catalyst in solving people's health problems and ultimately improve their lives. Last but not least, I would like to extend my appreciation to the organizing committee for successfully organizing this conference. I hope you will agree with me that the conference has been very well organized. Congratulations to the chairperson, Professor Simba, and his team. I would also like once again to congratulate MUHAS for marking the 60 years of existence and thank them for the dedication to the dissemination of health research outputs through these conferences and other symposia which have benefited this country tremendously. I urge you to continue with the same spirit and be assured that the government of the United Republic of Tanzania will always continue to give you full support. Ladies and gentlemen, with these remarks, I wish now to declare the MUHAS 11th Scientific Conference officially open. God bless MUHAS, God bless Tanzania. Thank you very much for listening.
Thank you very much, guest of honor. Another round of applause. Allow me now to request the high table to take this first row and invite Dr. James Kengia for the first keynote speech. Dr. James Kengia is the coordinator for research and publication at from the President Office Regional Administration Local Government, and he will present on behalf of the director, Dr. Ntuli Kapologwe. And as you see in front of you, he's going to deliver the keynote speech on health system strengthening and sustainable financing in addressing global health challenges. We all agree without a sustainable healthcare financing, all efforts, even with good evidence, will not change the poor health indicators that we have in our setting. Allow me to invite him and join me with a round of applause before he starts delivering his speech. Karibu, Dr. James.
Thank you very much, Mr. MC. Dear guest of honor, Professor James Mdoe, distinguished member from the high table, distinguished professors, dear delegates, ladies and gentlemen, taking this opportunity on behalf of Dr. Ntuli, who is my director for health, social welfare, and nutrition services at PURAG, to give a presentation as keynote address on health system strengthening and sustainable financing in addressing global health challenges in this 11th MUHAS Scientific Conference. I hope I will represent him with a twin. For the presentation outline actually has been clustered into 7 major areas for the benefit of international delegates and of course some of members who may not be aware of Tanzania health system. I'll provide a brief overview of background of Tanzania health system, followed by discussing a bit about the role of sustainable financings. And of course, from our core theme of this conference, I'll also talk about how can we build a resilient health system. And the other important area that I will embark into is, of course, highlighting a bit on the role of scientific evidence and innovations, and looking into our health systems. And in particular now, we are discussing about sustainable health financings. I'll also talk about the unfinished agenda, followed by looking to the future and some kind of a conclusion at the end. So in background, talking about Tanzania healthcare systems, we are really talking about a healthcare system that is well structured, and in particular, it is organized in a pyramidal shape. And of course, if we look at the base of the pyramids, you see the community, and above the community levels, you can see a series of healthcare facilities from the primary care to tertiary facilities and national level facilities. And of course, for Tanzania healthcare system, really the minister that is responsible, the sector ministry, we are talking about the Minister of Health here, responsible mandated for formulation of all the policies, guidelines, and standards, and us at PRAC responsible to oversee the administrative implementations. All those are developed by policies and guidelines by the Minister of Health. Of course, it's important also to highlight that during the implementations, we're also linking with important central ministries like the Ministry of Finance and Planning and President's Office Public Service Management. And down the systems, the important linkage in the implementation areas is usually the RAS, the Regional Administrative Secretary Office, where we have the team of regional health management teams members. And of course, if you go to the local government areas, there is a District Executive Director Office where we have the CHMTs. And as discussing about health system, it's important to note also that there are also different actors, important actors in the health system, including the training institutions like MUHAS and others, research institutions and agents such as MSD, Tanzania Medical Device Authorities. And of course, as now multi-sector coordination becomes important, the role of Prime Minister Office is critical in the Tanzania healthcare system. And talking about Tanzania healthcare system, Tanzania health system, PHC, primary healthcare, plays an important entry point. And in most of the literature, we realize that as you are discussing about health system that is vibrant and responsive, investment in primary health care is critical. In particular now, the talk of the day, we are talking about the universal health coverage. And in Tanzania in particular, the PHC journey started before independence, but you can also remember about the Arusha Declaration, where we have a lot of investment in terms of the PHC through Alma-Ata in 1978, and of course the Standard Declaration in 2018. All implementation dwells within the PHC pillar, including enhancing the equitable distributions of services, community participation, the issue of intersectoral collaborations, and of course the appropriate technology and the preventions. Said earlier, if we look into the healthcare delivery systems, the PHC contribute in terms of healthcare facilities of more than 79%. And here I'm talking about if you go to the health facility registry of the Ministry of Health as of today, we have around 11,000 facilities. And if you calculate the percentage of the available PHC facilities, it's almost more than 79%. This makes very important when you are talking about health system strengthening to think about the PHC level. And it's not only the facility there, the base of the big pyramids, we are talking about households that, of course, they live within the local government authorities. Primary care is important because, of course, majority of the peoples will tend to go to PHC level facilities as a point of entry for care, more than 85%. Of course, others will now be depending on the referral systems. They will now be referred to higher level facilities. But the base of the healthcare facility is important and critical in our healthcare systems. And in our setup, we really remember about the D by D, decentralization by devolutions. Well, that was very critical in around 1999 or 2000s, where we have embarked into D by D, decentralization by devolutions. That has facilitated or helped a bit in terms of improving the infrastructure development, of course, self-delivery, and availability of essential medicine equipment, supply, transport, and referral systems. Some of the evidence can be found in the literature. You can find it. One of the examples is a commentary that was, you can see on the slide, commentary on primary health care in Tanzania leading the way through innovations. And this commentary in the Lancet, you will find out that in Tanzania, after embarking into D by D, in around 1999 up to 2004, some of the positive gain came out in the healthcare system, including improvement in child survivals as one of the important outcomes. Of course, the reforms in those around 2000, D by D, aim to improve efficiency in the utilization of the development aid and avoiding duplication of efforts through what we call the SWAP, the sector-wide approach, through which the Health Sector Basket Fund was introduced. And from the Health Sector Basket Fund, it was possible now to plan at the level of the local government authorities by using the comprehensive council health plans. But apart from planning at the level of the councils and those positive gains, in around 2017, we have embarked into further decentralizations, a physical decentralization to the level of the facilities, what we call the DHFF, Direct Facility Financings, where through DHFF now we are able now to plan at the level of the facilities, dispensary, health centers, district hospitals, and likes. That means we are bringing now an issue of planning and resource allocation more close to the community. And by doing so, we are becoming more efficient. And apart from becoming more efficient, we are also responding to the community needs because the resources now are directed directly to the level of the facilities. From that introduction of background, let me go through now the role of sustainable health financings. And talking about health financing here is one of the very important pillars as we are discussing the healthcare health system strengthening. And building from the WHO health system building blocks is actually one of the important blocks in the health system building blocks. And now we are discussing about the improvement of universal health coverage by improving the supply side, talking about the effective service coverage. That is not only the utilization of services through improvement in access for healthcare delivery system, but of course improvement in the effective coverage, that is the quality. Through sustainable financing, you are able now to improve the availability of the services in the supply side. By doing so, then people could be able now to utilize the services. And the other important aspect is not only the supply sides, if you are having the sustainable financings, the other key and critical area is on the demand sides. Having sustainable financings, you're also able to have people able to access care without succumbing to catastrophic expenditure. I'm talking here about the financial protections when accessing for the healthcare in the facilities. This is because to date we have a number of people that are failing to access services because of the cost on the demand sides. But of course, apart from the cost, the other area is people might be able to pay, but the availability of the services is critical. So thinking about sustainable financing is important because you are not really making your financing, your systems ready for the patients or client to come and receive the care. So with the WHO health financings, some of the recommendation is really to have a very good system that it can raise the revenue. Revenue is critical from the different diversity of sources. But of course, the pooling of funds is another very important area as we're discussing sustainable financings. And the pooling of funds is one thing, but the important other thing is where the fund is being directed. Talking about here the purchasing of services. And really, the strategic purchasing is one of the critical areas that is advised when it comes into purchasing of services. Here, talking about purchasing services that is depending upon the population needs. And of course, it could be also related to the performance of healthcare providers. And discussing about sustainable healthcare financings, one of the important reports that is also, you can go and read it, that also provides us a lot of information when it comes into landscape of the financing of primary health care. The recent Lancet Global Health Commission on Financings that can be available in the literature by Hanson et al. 2022, that actually argues that one of the important areas when you're talking about investing in health systems is PHC. Primary health care is a key component of all high-performing health systems. So in high-performing health systems, PHC investment is critical. And of course, it's an essential foundation of UHC, universal health coverage. So all countries are really advised the need for both investing more resources to PHC, but not only more resources, but thinking about the best way of investments that, of course, can guarantee improvement in access to individuals in the communities. But the other thing is advocated by the Lancet Global Health Commissions is the importance of allocating and protecting sufficient funds for the primary health care, and of course incentivizing providers to maintain the health of the population they serve. And through this report, if you can go and deep dive and read on this report, you are able now to understand when it comes into the financing landscape for the PHC, from the low, middle, and even the higher developing countries. Just to summarize in this report, you'll find that talking about the government spending of PHC, in particular in low and lower middle income countries, is actually very low. We are really talking about $3 for the low income countries and lower middle income countries of around 16. Comparing to WHO estimates of the per capita recurrent cost for PHC that is advocated at the level of $65 per capita in low income countries and $59 per capita in lower middle income countries. So you can see generally in most of the low and middle income countries, the per capita spending to PHC is extremely low. But of course, if you deep dive and understanding the funding profiles at the PHC levels, you'll find that the financing aspect for the PHC is highly fragmented. And of course, with a very low government spending, and one of the critical areas is there's high out-of-pocket expenditures. But also there's high share of external spendings. And if you look on the upper left on my sides, there the graph what it shows that we're talking about here more when it comes into government spending. Government spending in low and middle income countries, most of the government spending is really directed to, you can see there on the legend up there, for the government spending, the more is spent on the outpatient care. And talking about outpatient care here, most of the resources, of course, direct towards the human resource for health, the salaries and the likes. The middle area there for when it comes into spending in low income countries, you see that the donor spendings, most of the donor spendings is directed, the large portion there, on the prevention services. But what is critical here is the fact that most of the donor spending is directed to the prevention services, but in particular to some very unique specific disease conditions. That means there's a lot of fragmentations, and tapping resources for the PHC becomes difficult, especially when we are trying to embark into more integration of services. And the last one there, you see, when it comes into out-of-pocket spending, the majority, it goes to medical goods. That means, according to this report, most of the resources from the out-of-pocket people spend for the medical goods. Here talking about medicines, in particular outside the healthcare systems, not availing them at the OPD, but they will go outside and purchase those kind of medicines. So a lot of resources is being directed to that angles. So further informations in Tanzania context in particular now, we usually conduct the National Health Account. And the most updated National Health Account is of 2022. And if you read on the report of National Health Account, what is important when it comes into financing landscape in Tanzania, the good news is we have increase in domestic financing of Tanzania's expenditures. From 2005 to 2019-20, increased from 59% to 63%, while the share of foreign financing is declining. You can see from 41% to 34%. But what is really important here is not the good news of having a lot of domestic financing increasing. But one of the critical areas there, the majority share of the domestic financing is really coming from the household spending. And here is more of out-of-pocket expenditures. What does this mean? This means that you have a lot of spendings in the domestics, but most of the resources is really from out-of-pocket expenditure. Out-of-pocket expenditure, it has a risk of succumbing to catastrophic health expenditures, in particular for the individual who are the poorest in the communities, due to the regressivity in nature. You have kind of a regressive financing when it comes into spending more of out-of-pocket expenditures. People who are poor, the poorest, pay more than their ability to pay. That means it is important really to reorganize our health systems to ensure that these large portions of money that is paid via out-of-pocket goes to prepayment schemes such as the insurance. By doing so, you are able now to ensure that people can really access services in the absence of catastrophic health expenditure. And the other important area, on the National Health Account, you will find out that the main source of health sources in Tanzania over the recent past, as I said earlier, is household and donors. If we disaggregate from the previous slides, you'll find that the main source now is two. You are talking about the household and donors become the top contributor. But of course, I've already talked about the household. The main real contribution there is the OP, out-of-pocket expenditure. So building from all those that we have discussed about the landscape of healthcare financings, now embarked into building health system resilience, it is important to realize that as now we are really facing a lot of challenges in the healthcare sectors, in particular from natural calamities, but of course with the recent emerging and emerging diseases such as the COVID-19, our health system needs to be really resilient. And there's a lot of discussions globally, one of which is the Global Symposium on Health System that was conducted in 2016 in Canada with the title Enhancing Health System Resilience, in particular to stimulate countries to be able to absorb shocks from different sources, including those of natural calamities and emerging diseases. And in particular, what is really advocated here is to have a health system that is able not only to respond on the shocks when it happens, but rather also to plan for those which are foreseen events. Planning is critical for those foreseen events. And for that one, in particular, WHO has, of course, gave kind of a position paper launched in 2021 on building a system resilience for universal health coverage and health security. And one of the recommendations, they gave 3 core recommendations. And of course, we cannot run away from the PHC. The first topmost recommendations in building resilient health systems is to improve, protect, and restore health system by building strong PHC system, primary care, for bringing health services closer to the communities. And of course, the issue of institutionalization of all hazard emergency risk management, and of course, the concept of enhancing intersectoral collaborations, working with different actors is important and critical. Now, from our themes, I'm going to talk a bit about the role of scientific evidence and innovations. One of the very good report that you can go and read it, WHO report 2013, Research for Universal Health Coverage. One of the recommendations in this report is the fact that it is important to have research. Research brings evidence. Evidence that is being advocated here, in particular for the UHC, is the research work that can be tailored to our local needs, and of course coming up with some innovative local solutions. Talking about here, research work to inform to inform practice, and of course sound policies. Of course, through research works, we are able now to gain some efficiency in our healthcare systems, but of course, designing of appropriate interventions to be response towards the needs of our communities. But what is important, learning from the experience at PORAC, this kind of research works need to be collaborative. At PORAC, we have started this kind of coordination work, and we usually conduct kind of a research camp, including researchers from the universities. Some members are from here, MUHAS, but of course we partner also with the CIFCAS, St. Francis Universities, University of Dodoma, and the KSMC, Kesemuko. We sit together and really doing kind of research works that can be tailored to the common research agenda. And thanks to NIMRI, they have already developed a national research agenda that really is a very good guidance that we can work together to ensure that we are really doing research that is responding to the local need of the populations. Of course, there's a number of publications that can be seen from this collaborative work that is available, we could share, but available in the literatures. But something else that I need to air out here is the importance of really also investing into a very systematic approach in building evidence for policies. And there's a very good platform that we can also invest upon. The WHO, they have the HEVIPNet. That is the Evidence-Informed Policy Network. And as PORAG, with a number of individuals in the university who have registered into HEVIPNet, it's there for us. There's the opportunity for building kind of a capacity in country capacities to be able really to synthesize the knowledge that you are really preparing towards informing good policies. And of course, building from that one, from this evidence hierarchy pyramids, most of us, probably we are at the center there doing a lot of RCTs, cohort study, case control studies, and the likes. But really, as you are now thinking about evidence for policy and the practices, it's important to go higher up, doing a lot of systematic reviews and, of course, meta-analysis. And for the innovation aspect, the other important thing is for us at PORAC, we also developed what we call the Health System Strength and Resource Center. That is important, in particular, to how can we really tap the lot of innovation that happen at the local government authorities. From all those innovations, we are developing a mechanism to tap them and really gather them in a way that we can inform the policies. And we work together collaboratively with universities. And of course, we have MOU with MUHAS, UDOM also have MOU, and we're establishing a number of MOU with the other universities. As I'm navigating toward the end and finish the agenda, talking now, reflecting from what I have been talking about, there's high reliance on out-of-pocket payment, as we're discussing here about financings, sustainable financings. but high dependence on external financings. But with our insurance scheme is very low. And as we're looking now into the future, it is important that we realize our universal health insurance bill. I think this is an area where the researchers also need to embark into and come up with some evidence how best can we build our UHI, universal health insurance. But of course, universal health insurance is one of the things, but additional funding to complement the UHC is important from the general budget support. But another very critical area, as we're talking about sustainable financings, is also to embark into efficiency. The small resource that we have is important to use it efficiently. And here I'm talking about the integration of services. I know that the NIMBRI here at MUHAS Center, they did one of the study, a very good study on integration between NCDs and HIV/AIDS. Those kind of innovation is important to gain efficiency with the little resources that we are having. Of course, harmonization of partners is important. We have a very matured sector-wide approach centrally, but we need to improve the coordination, the level of subnational levels, to ensure that the resources, the little resources that we have, is really utilized efficiently. And the other thing is to strengthen strategic purchasing. But of course, we need also to think about the bigger picture of health system. Improvement of quality of care is important. We need also to accommodate the emerging issues. We're talking about here the double burden of diseases with the NCD at the level of the PHC. It's important that we have systems for early diagnosis and treatments. Enhancing intersectoral collaboration in other important areas through mechanisms like the One Health and Health in All policies that has been coordinated at the Prime Minister's office. Of course, improving management and governance at all levels is important. But another very important area is, of course, to have effective system for monitoring and evaluation in the spirit of surveillance to enable swift action. This goes parallel with conducting research works. And other important area is really to move from a curative care towards people-centered care. We need to invest because the patients are coming to our facilities. Before they are coming to our facilities, they are in the community. We need to invest on health promotion activities under the concept of people-centered care. You can read more on it. It's available in the internet. This document by the WHO 2007 People-Centered Care Policy Framework that is advocating more for health promotions. And health promotion here for our people in the community, but to overemphasize also of looking into even the staff, because we are forgetting staff, healthcare staff. Healthcare staff, we are part and parcel of the community. And the other important area is also to invest on community health systems. This paper, it has highlighted the need for investing for the communities. Talking about here, there's a lot of discussion about the community healthcare workers and structuring the communities. How can they be effective to support the healthcare delivery system? In conclusions, point number one, investing further in PHC is key for achieving UHC and addressing global challenges. But when it comes to financing landscape, a paradigm shift is needed for improving the prepayment system in Tanzania. A move towards a more progressive financing mechanism is important here, where we are able also to accommodate the poorest of the poorest. Investing in people-centered care, as said earlier, and having a very strong system for monitoring and evaluation. Having said that, asanteni sana kwa kunisikiliza. Thank you very much.
Thank you very much, Dr. Kegia. I think the applaud is not enough. Asante sana for that very strong lecture on health systems. So now I will request the members of the high table and the following groups. The organizing committee, representative from the ministries, the MUHAS and sister institutions, that is MNH, ORAS, JKCI, and MOI, Thank you. Together with the international collaborators, to join the guest of honor to have a group photo as the memory for this event just outside this building. And that will be followed by a media session. While the media session is happening, we will be marching to the posters so that we can have time to appreciate have put for us as evidence for strengthening our health systems. And of course, that will be followed by lunch. So, high table, under the leadership of our very own Professor Apolinarika Muhabwa, will you please stand and the other groups and get us. He's asking me after lunch what will happen. We'll be going to the parallel sessions to respective venues as stipulated in this booklet, which I am informed that all of you have been provided. Thank you very much, and karibuni kwa sessions zinazofuata. And that's mark the end of the opening ceremony, ending my employment this morning.
Forever, labda tutalala. So, Tarsila was there. Muhammad is there. Salma is missing. Fatima is there. Raya is there. Okay, do we agree to start? Are we ready to listen to science? Okay, you're welcome, Dr. Tarsila.
Good afternoon. As introduced, my name is Tarsila Joseph Asenga. I'm the resident pediatrics and child health, third year. Thank you.
My name is Raya Ali Hamad. I'm a resident from pediatric and child health.
My name is Mohamed Zegidius, a third-year resident in obstetrics and gynecology.
Good afternoon. My name is Fatima Versi. I'm a final year resident in obstetrics and gynecology.
So I'll present my work titled Clinical Profile of Children with Autism Spectrum Disorder and Experiences of Their Parents in Dar es Salaam, Tanzania. And I was the principal investigator. So my supervisors were Dr. Samafilan Ainan, Professor Karim Maj, and Dr. Amy Mehta. So what is autism? So autism spectrum disorder is a neurodevelopmental disorder which is characterized by deficits in social interaction, in verbal and nonverbal communication, and these children also have stereotyped, repetitive, or restrictive behaviors. So globally, 1 in every 160 children has autism spectrum disorder, and this was reported by WHO in 2012. And the most recent data was in the United States, where in 2021, it was reported that 1 in 44 children has autism spectrum disorder. So this is a disorder in which these children have impacts in the community and in the families, which usually noted are the social, society, educational, psychological, and economical impacts. So this study was aimed to gain insight into their lives. So the main objective was to assess the clinical characteristics of these children and to explore the experiences of their parents with the specific objectives of describing the clinical characteristics and the comorbidities, also to explore the care-seeking pathway from the onset of symptoms to seeking care, to explore parents' knowledge and coping mechanisms employed while raising these children, also to assess the type of support that these families get. So this was a cross-sectional study. It was a mixed method, qualitative and quantitative study, which was done from September 2022 to April 2023 at MNH Pediatric Psychiatry and Occupational Clinics. It was also done at Avicenna Clinic in Upanga. So in a quantitative study, 245 children were consecutively, it was a non-probability consecutively sampling. And these children selected were aged 1 to 12 years, which is in line with the age, mostly age of presentation and diagnosis. So the analysis was done, data entry and analysis was done using SPSS version 23, and the data collection tools which were used were standardized structured questionnaire and also to revisit the clinic records. Also 10 parents were purposefully selected for qualitative study. So these parents were selected depending on their age, on their level of education, employment status. So that's the meaning of the purposeful sampling. And these children the parents were those who had stayed for children for more than 6 months, they had more experience, and this was to get heterogeneity of data. So in-depth interview was conducted using questions which are adapted from the study by Achari et al. And a thematic analysis was done by the support of NVivo 11 Pro program. So 250 children with autism were selected from the clinics, of which 5 mothers did not consent, so I ended up with 245 children who were recruited. So I selected 123 patients from psychiatry clinic, 82 patients from occupational clinic, and 40 patients from Vicena clinic. So this was done according to the number of children who attend these clinics. So this is the figure 1, which shows which is the flow diagram which showing the recruitment of the study participants. I hope you can see this clearly. So on the socio-demographic characteristics of those children who were selected, majority of these children, 66% of them were male children with a mean age of 6 years. And most of them fell in the age group of 5 to 8 years. And the age at onset of symptoms was noted to be 2 years, and age at diagnosis was 4 years. So the symptoms that were noted, 60% of the children presented with delayed speech, and 40% presented with reduced or absent social interests, followed by delayed developmental milestones. And the comorbids that was mostly noted was the behavioral disorder, and the behavioral disorder was defined as severe tantrums, self-injurious behavior, and also so severe tantrums, self-injurious behaviors, also those who had, so those two, and followed by epilepsy. So these were the comorbids that were mostly described by the parents. So after doing a quantitative study, a qualitative study was done to get more insight into these children. And the most parents also reported that their children presented with symptoms mostly at the age of 2 years, and most of them presented with delayed speech. So you can see in the qualitative study, one of the themes was a diagnostic process, of which in the sub-theme reported were the symptoms which triggered seeking care. As I said, most of them had delayed speech. So one of the parents I caught reported that at 3 years, he wasn't speaking yet, he wasn't socializing with his peers. So you can see this is even in line with the quantitative findings. Also, these parents, most of them had to see more than one health practitioner before they got their diagnosis. And as we noted, there was a 2-age gap between the time that the parents noted symptoms to the age that they got their diagnosis. So they reported that they had to hop from one hospital, from one doctor to the other for them to get the correct diagnosis. And this was the most difficult time for most parents. So one parent reported that she used to take the child to pediatrician, but still they were told that the child was fine, and most of the symptoms were in line with they were told that it was in line with the normal developmental age. That's why which explains the delay in diagnosis. So another theme was the challenges faced by parents. So these parents described the stigma that they faced, the psychosocial burden, the emotional stress. They felt that they were neglected. So in social stigma, because these children have abnormal behaviors, so most parents reported that they felt they had to withdraw themselves from social events. They couldn't attend with their children because of the way they acted, and most people judged them that they did not raise the children well. So as one parent reported that when he starts his tantrums, people don't understand. They say that he is not raised well. On the psychosocial burden as well, so this is a children that it's difficult to leave them with another caretaker, or most parents were forced to leave their works to stay home and take care of their children. And these parents, as I said, they reported that they felt their needs were neglected. Like most of the time, it was the children were taken care of, but these parents, the stress that they were going through, the physical exhaustion, these were not addressed when they came for clinics. So one of the parents said at least once a month, a psychologist should meet with the parents because no one is taking care of the parents. Another problem was the accessibility of care. So some of the parents I interviewed had to relocate to Dar es Salaam or to shift their work so that they can be able to access the care. Like one parent reported that she was in Twara, so she had to travel every week to bring the child. So she had to use bus fare, and then she had to ask for excuses at work from time to time. So they become exhausted, and eventually some of them feel like giving up. So in this study, we also saw the coping strategies which were used by families. So most parents reported that they were consoling themselves. Like when they're coming for clinics, when they see other children who are worse than their children, that's a consolation for them. Or when they come for clinics, because at first when you have a child who has abnormal behavior, you don't understand what is going on with the child, and then you start coming to clinic and realize that you're not the only one. So that for them was also a consolation. And another consolation was a religious coping strategy. So they were praying, fasting, listening to gospel. Like one parent quoted that, "I prayed a lot, that is what helped me to be at peace." And others also had to learn about autism. So they had to Google or they observe and see what was done when they come for clinics, and that they were doing it at home. Another thing, they had to do family adjustments, like no screen time. They had to cut off soda juice because this was causing them sugar rush, and the children were more active. Another thing they learned on was the family and social support. Like one parent I quote, he said, "The good thing is I have a partner who understands, so we support each other." So these parents also had different understanding of autism. They had different perception of autism. There are those who had good understanding. There are those who just only knew that their children are autistic, but they did not know what autism is. So there was a varied level of understanding. Like one parent reported that it is a lack of mental development. So in conclusion, in this study, it revealed that males are more affected than females, and this is also seen globally. And the mean age of onset of symptoms was 2 years, but the age of diagnosis was 4 years, so there was delay in diagnosis. Delayed speech, absent social interests were the most common symptoms which were noted, and behavioral disorder like self-injurious behavior, aggression, and severe tantrums was the most occurring comorbid. So these parents faced social stigma, psychological stress, difficulties accessing care. They also relied on family and social support, praying and learning about autism, also doing adjustments at home to fit their children's lifestyle. So the recommendations are, so from this study, we feel that there's a need to screen these children according to the recommendation by the American Pediatric Association, as this will facilitate early detection of autism. So it's usually recommended to screen these children at the age of 18 months. Also to do family-centered services, which will help parents cope better with the challenges of their children. And another study should be done at the community level, because this will give a true presentation of the problem at large. Thank you.
Thank you so much, Tarsila, Dr. Tarsila. I think we've all heard about this very frustrating illness. That my question comes to Tarsila, but don't answer it now. Can you know it intrauterine, because I'm a gynecologist. I'd like to know if we can screen for autism before the babies are born. I had a friend, we met during my PhD time in Sweden. She had infertility for a long time, and then she adopted, and then she got pregnant, and she was very happy. And when the child got to 10 years, first, from 5 years, the child started behaving funny. We're like, what is this? Maybe the mother is just very lenient, memdekeza mtoto. And everybody was like, no, you have to be hard on him, be hard on him. And then in the long run, he was diagnosed to have autism. My friend went mad. She stopped everything. Her life changed. It is just a bad experience, yeah. So I'm happy that we are now, I don't know now if it's becoming more common or we are diagnosing it easily now, I don't know, but it's like it's gaining, it's becoming very. Now we go to the second presenter. Who is the second presenter? Dr. Muhemes. I think he introduced himself. So keep your questions for Tarsila, and then we listen to Muhemes, and then at the end we will have questions for the whole panel. Thank you.
Good afternoon once again. I'm very much honored for this opportunity to present my research at this esteemed scientific conference. Today I will be discussing on my study with the topic reading factors associated with sexual dysfunction among postpartum women attending Mnazi Mmoja Hospital in Dar es Salaam, Tanzania. Sexual dysfunction in postpartum period is the topic of great importance as it has a negative impact on women's sexual health and well-being. Sexual dysfunction, studies have shown that 50% are at increased risk to experience sexual dysfunction after childbirth. Globally, the prevalence rate varies from 20% to 80%. The hormonal changes, physical, psychological, and cultural influences have all been reported as determinants for this problem. During postpartum care, assessment of sexual dysfunction remains a challenge to many of health professionals, despite its negative impact it may have on the women's sexual health and their partners. Therefore, the evidence from this study might provide the insights towards the assessment and interventions to improve sexual function after childbirth. The specific objectives of my study were to determine the magnitude of sexual dysfunction among postpartum women, to identify the types of sexual dysfunction, and to identify factors associated with sexual dysfunction following birth. To achieve these objectives, we conducted a cross-sectional study at Mnazi Mmoja Hospital involving 424 postpartum women within 2 to 12 months of delivery. To gather participants' information, we used structured questionnaire and female sexual function index to assess the sexual function. The responses were analyzed by SPSS version 23 and a chi-square test and multivariable analysis were done to identify the independent risk factors. Our analysis therefore revealed a noteworthy findings as shown in these tables. The mean age of women studied was 28.94 with a standard deviation of 60.032. The majority were aged between 20 to 30 years of age, and significant number had received some form of partner support. However, less than half of them were not in the marriage. So with the obstetric characteristics, more than half had given birth within 6 months, and above 2/3 had a parity of between 1 to 3. The majority delivered vaginally and exclusively breastfed their infants within 6 months of delivery. Additionally, there was 42.5% of women who were on contraception, and the hormonal type was highly used. Therefore, the proportion of women with sexual dysfunction among studied participants was 73.6%, and the arousal disorder was the most experienced form of this problem. Our analysis with the chi-square showed 4 variables with significant association. However, due to the possibility of confounding effect among these variables, the multivariable analysis was therefore done. The parity time from delivery, partner support were the variables with a p-value less than 0.2, and all of these were just subjected to modified Poisson regression model to control the confounder. The multivariable analysis showed that shorter time from delivery and the lack of partner support were the independent risk factors for postpartum sexual dysfunction. The women within 2 to 6 months of delivery were 1.27 times more likely to experience sexual dysfunction. And the lack of partner support increased the likelihood of developing sexual dysfunction among postpartum women by 1.21 times. The prevalence of postpartum sexual dysfunction was therefore high, which is similar to studies done in Turkey, southern Iran, and recently done study in Rwanda. Our study identified shorter time after delivery, lack of partner support as main determinants, which is contrary to some previous studies that have identified other factors such as maternal age and education to be the determinants. Surprisingly, no significant association was found between sexual dysfunction and delivery mode, birth complications, and contraceptive use, despite their known potential effect on the sexual well-being among these postpartum women. In conclusion, the prevalence of postpartum sexual dysfunction was high and likely to occur in early postpartum period and among mothers who lacked partner support. Among others, arousal disorder was the most common form of this problem in the affected individuals. We therefore recommend that health care providers should assess and encourage partner involvement and support in all aspects during the postpartum period. And women should openly share their sexual concerns to allow comprehensive assessment and intervention to be implemented, particularly in the postpartum period. In future, further research is needed to validate our findings and explore additional factors which may affect this sexual well-being. Researchers should also assess the impact of postpartum depression and the cultural influences on postpartum sexual function and use objective measures to assess partner support. Thank you. This marks the end of my presentation.
So much, Dr. Mwemezi, and the audience for listening. This is a very important topic that I think is not discussed much, almost forgotten, but it's very important. When I was on MD 3 or 4, one day the nurse was discharging postpartum women, and she told them a lot of things, but one thing she said, and I was like, what? That after, baada ya wiki mbili, baba akiomba, unampa. Sawa? Like, oh! That you are ready to go back to your sexual life after 2 weeks. And then I kept asking myself, after 2 weeks, is it right? But once I had a client who, I did cesarean section and she asked me to do BTL and I did it. And then when she came for stitch removal, she asked me, doctor, did you tie my tubes? I said, yes. Are you sure you tied my tubes? He said, yes. Why are you asking? My husband came, so there's no option. I'm like, okay, so 1 week is also okay. 1 week post-cesarean section. I was like, oh? So it's very individualized. Yeah, everybody has their own ways, their own things. Like Mwemezi is telling us, there are a lot of factors that affect this. So keep your questions for Mwemezi, and we go to the next presenter. I'm happy that everybody is keeping time. Dr. Fatema, you're welcome.
Right. Good afternoon, everyone. My title was on the factors associated with the uptake of immediate postpartum IUCD amongst mothers who gave birth at regional referral hospitals in Dar es Salaam. My name is Fatima, as I introduced myself, and my supervisors were Professor Kileo and Dr. Furaha. So we all know intrauterine contraceptive device, but my study was focused on the postpartum one that is usually inserted following the delivery of the placenta and within 48 hours. So the immediate postpartum IUCD is an effective and convenient method, as it may be inserted immediately or within 48 hours following delivery, ensuring that the mother is discharged when already on contraception. In 2013, FIGO, the International Federation of Gynecology and Obstetrics, launched a multi-country initiative to institutionalize the postpartum IUCD in 6 countries that included Sri Lanka, Bangladesh, Nepal, India, Kenya, and Tanzania. So FIGO officially launched the program in Tanzania in 2015 to institutionalize the PP IUCD as part of the antenatal care and delivery room services in Tanzania. And a total of 2,699 health workers were trained on postpartum family planning counseling and insertion. Amongst those interviewed before delivery, 5.8% opted for and were inserted with the postpartum IUCD. Despite the many efforts put into this training and the many known benefits of the postpartum IUCD, the uptake continues to be low. The uptake rate was approximately 13.1% by 2018, and the reasons for the low uptake were not assessed. Despite the high effectiveness of the IUCD as a method of family planning, it still remains underutilized in Tanzania with an uptake rate of 0.9%. This is for the intrauterine contraceptive device in general and not just the postpartum intrauterine contraceptive device. So my study was a descriptive cross-sectional study design that was done at Amana, Mwananyamala, and Temeke, and my objectives included, the broad objective was to determine the factors associated with the uptake of the immediate PP IUCD amongst the mothers who gave birth at regional referral hospitals, and the specific objectives included to determine the proportion of women who utilized this method among women who delivered at the mentioned hospitals, and to determine the factors associated with the uptake of PP IUCD amongst mothers who delivered at the following hospitals again. So the socio-demographic in the table for the socio-demographic characteristics as it is displayed over there, you can see that most of our participants, 42.6% of our participants were between 25 to 34 years of age, with a median age of 27. and approximately half, 51.5%, had no formal to at least primary level of education, and more than half, 60.8% of the participants were either married or cohabiting. In the clinical and obstetric characteristics of the study participants, 59.8% had a parity of 2 to 4, and most of the participants, almost half, 42.3% of the participants had a booking GA of 3 to 5 months, and most had made more than 4 antenatal clinic visits. Family planning counseling was provided to more than half of the participants, 55.33%. So for the first objective, proportion of the postpartum IUCD, so amongst 423 women, only 35 of them chose this method, making it to 8.27% of uptake. In the factors associated with the uptake, as you can see, age was significantly associated with uptake. Those who were aged 35 to 54 were 3.91 times more likely to uptake this method as compared to those who were 18 to 24 in the multivariable analysis. The other two factors that were associated with the uptake were the booking GA and the mode of delivery. Those who booked at less than 3 months were 11.1 times more likely to uptake this method as compared to those who booked at more than or equal to 6 months. And those who delivered vaginally were 6.84 times more likely to uptake this method as compared to those who delivered through cesarean section. So age, booking GA, and mode of delivery were significantly associated with its uptake. I've mentioned this. So overall, the uptake of PPIUCD was low at 8.27%, and the uptake was noted to be low globally, with a similar uptake in Ethiopia at around 12%, and slightly higher in Rwanda and India at 28.1% and 20.2%. The variation of uptake may be due to difference in the level of awareness, educational level of respondents, various misconceptions of the postpartum IUCD insertion in these studies may also contribute to the differences. So in my conclusion and recommendations, enhancing educational level of women and effective IUCDs counseling during antenatal care visits is important. Educating women on the details of this method is recommended as well, and further studies are required on the part of providers to assess the reasons for low uptake. Thank you.
Thank you so much, Dr. Fatema, for bringing this up. Yeah, it's sad why women are not taking this up, and yet they come with unwanted pregnancies and unwanted abortions and stuff. And this project was very well funded, but the uptake is very low. Someone has to take this up and know why and what we should do to have unwanted pregnancies. So the next presenter is Raya. You're welcome, Raya. Keep your questions, please.
Good afternoon, everyone. My name is Raya, and I'm from Pediatric and Child Health. I'm here today I will share with you my research results titled Effective Breastfeeding Technique and Associated Factors Among Lactating Mothers in Dar es Salaam, Tanzania. My supervisors are Dr. Nahia Salim and Dr. Mariam Nurani. So what is a breastfeeding technique? So breastfeeding technique is the position of the babies, the position of the mother and infant, baby's attachment to the breast, and suckling during breastfeeding. So it is important to use effective breastfeeding technique in order to promote breastfeeding. So the global prevalence, by the study done by Yelak et al., it was revealed that the global prevalence is ranges between 36.5 to 52%. So WHO has recommended to use effective breastfeeding technique so that to ensure the baby can get expected amount of energy and nutrients, and also to ensure the mother's comfort. So the main objective of this study was to determine the prevalence and factors associated with effective breastfeeding technique among lactating mothers in Dar es Salaam, Tanzania. So it was a hospital-based cross-sectional study which was conducted at Mnazi Mmoja and Aga Khan Hospital, and all lactating mothers with newborn within 2 weeks of delivery were included. And data was collected by using structured questionnaire and observational checklist. So this table represents the tool which was used to assess breastfeeding technique among lactating mothers. So it is a validated tool which have been used by other studies similar to our setting. And in order for a lactating mother to have effective breastfeeding technique, she should meet all 3 techniques. That means she should meet at least 2 criteria and above from positioning, 3 criteria and above from attachment, and 2 criteria and above from suckling. So the results. So this is the table which represents social-demographic and clinical characteristic of the study participants. So a total of 435 lactating mothers were enrolled in this study, and there was a similar proportion at Aga Khan and Mnazi Mmoja Hospital. Okay, so this figure, it represents the independent technique score among lactating mothers, whereby it shows that most of the mothers, they have good positioning, and about half of the mothers, they have good attachment and good suckling. So the overall prevalence of effective breastfeeding technique among lactating mothers in this study was found to be 38.16%. Okay. So also, this is table 3, which shows social-demographic and clinical characteristics associated with effective breastfeeding techniques. So the factors that were found to have significant difference were parity, educational level, and support by healthcare workers. So on multivariate logistic regression, after controlling the confounder, the factors that have been shown to have independent association with effective breastfeeding technique were parity, educational level, and support by healthcare workers. Whereby in parity, multipara had higher odds of 3 times higher odds of practicing effective breastfeeding compared to the reference group, which are primiparas. And also in educational level, those mothers who have secondary and college education had higher odds of having effective breastfeeding compared to those mothers which have primary education and below. And also, lastly, those mothers who report to have support from healthcare workers had higher odds had higher odds of practicing effective breastfeeding compared to those mothers who reported that they did not receive support from healthcare workers. So in conclusion, the prevalence of effective breastfeeding technique among lactating mothers in this present study was low. So the factors such as parity, healthcare workers support, and educational level have been found to have positive contribution towards effective breastfeeding technique. So the recommendation is that healthcare workers should be empowered to provide support to lactating mothers and to achieve effective breastfeeding technique. Furthermore, more studies are recommended to further explore barriers and enablers to effective breastfeeding technique and health education approach towards lactation. Thank you very much.
Thanks a lot, Dr. Raya. I hear the 5th presenter is here. I should not talk much. You're welcome, Dr. Salama. Please keep your questions for Dr. Raya, and we'll listen to Dr. Salama's presentation. Karibu.
Good afternoon. My name is Salama Khamis Ali. I'm presenting a research with the title Socioeconomic and Environmental Determinant of Diarrhea Disease among under 5 years children in West B District, Zanzibar. And my supervisor was Dr. Mohammed Hussein, and co-supervisor was Magdalena Shayo. So diarrhea disease is defined as a passage of 3 or more loose stool per day. About 1.5 billion cases of diarrhea reported, and it kills about 500,000 and 25,000 under 5 children every year globally. So age, education level of the mother and caregiver, low economic status of the family, and source of drinking water, sanitation facility, waste disposal, and hand washing facility in household reported to be associated with diarrhea disease. The Sustained Developmental Goal number 3 and the UNICEF both together target to eradicate waterborne disease by improving wash-related determinant. School wash program, Zanzibar Urban Water and Sanitation Program, and Zanzibar Comprehensive Cholera Elimination Program all together focus on safe water supply and sanitation. So diarrhea is an important cause of death, accounting for 10.8% of all children deaths in Zanzibar. Zanzibar reported to encounter continuous diarrhea attack with high peak prevalence during rainy season. Socio-economic and environmental factors are highly related to explain the persistent nature of diarrhea disease in Zanzibar that ag research on these factors. So despite high prevalence of diarrhea disease in this area, still the area is faced with the challenge of inadequate and poor supply of safe and drinking water, poor sanitation and solid waste management. The area also is faced with pervasive urbanization, and currently there are a few published reports on influence of socioeconomic and environmental factors. So on the research objective, general objective, the general objective of the study was to identify socioeconomic and environmental determinant of diarrhea disease among under 5 children in West B District, Zanzibar. And on specific objective, the first objective was to determine prevalence of diarrhea disease among under 5 children in that area, to identify social factors, affecting diarrhea disease, to determine economic status, risk for diarrhea disease, and to identify environmental and determinant factors. So on conceptualization of the research, the diarrhea disease seemed to be influenced with this factor, and also these 3 factors, social, economic, and environmental, also had inter-association between them. So the study design was community-based cross-sectional using quantitative analytical approach. It was conducted at West B District, Zanzibar, and the study population was 6 to 55 years, month of age children. And the sample size was obtained using the sample from a normal sampling distribution, considering the proportion of the probability of the problem with the consideration of non-response rate of 10%. So the sample size obtained or used was 252 children. Sampling technique forwards selected purposively, and multi-stage sampling and probability proportion to size was used to identify exact number to enroll from each wards. Interview form and observation checklist was used as data collection instrument. To ensure validity and reliability of the study, principal researcher participated fully on the collection of data. The research assistant was trained, and the interview form was pre-tested before the conduction of the study. So our outcome variable was prevalence of disease, and explanatory variable which we were to assess was social, economic, and environmental determinant. So on the study analysis was done using Starter version 15. Also ethical consideration was considered. Approval sought from the university and also at the study area. Also at the study area, the approval was sought accordingly. So on the finding, the first objective, the prevalence of diarrhea disease was found to be 10.71%. And on second objective, the age of the child and age of the mother was found to be to have a strong association with the outcome, the diarrhea prevalence. And after controlling of all confounders, education level also was found to have a strong association with the diarrhea disease. And on economic determinant, the principal component analysis give out the population was the highest population, accounting for 21.83%, was fall onto poorest quintile, and the smallest percent fall onto the richest quintile, accounting for 17.46%. So the wealth index revealed no association with diarrhea disease. And on environmental factors, child stool disposal and toilet sharing was found to have a strong association with diarrhea disease. But after controlling all possible confounders, there was no any other variable which was found to have statistical significances. So this is a table showing the variable with the strong association with diarrhea prevalence. So to conclude, the study revealed that young age of the babies, young age of the mother or caregiver, education level of caregiver, toilet sharing, and unsafe child stool disposal was a strong associating factor with diarrhea disease among under 5 children. The study recommends that ministry should develop an intervention to empower women or to educate women on the care of the children, and at local government should invest more on making campaign to the community about encouraging people to improve use improved toilet and to discourage sharing of toilet, and at community level members are advised to facilitate proper waste management and to practice safe child stool disposal. Thank you for listening.
Thank you so much, Dr. Salama. Yeah, diarrhea is another illness that at this century should have been eliminated, I think. So it's sad to have it up to now. And the prevalence is high. And I think your way forward is okay. Now the floor is open for discussion. We'll be taking 5 questions. We started at 1:15, so we have like 8 minutes for questions and discussion and comments. Karibuni, msikilize maswali yenu.
Yeah, thank you everyone. Thank you for your presentations. I have 2 questions. One to the one who present on sexual dysfunctions, and the second one to Dr. Fatima on postpartum, IUCD within 48 hours. So to start with the one who, sorry, your name is? Mwemezi, yes. I think I was trying to think with a family issue and home environment. For example, there was a time I did a study in Kongwa, and in Kongwa it was on postpartum issue, and there was a concept known as kumtima. It's like kubemenda issues, whereby it depends on the sex of the baby, whether it's a female or is a male. There was abstinence maybe 3 to 4 months for the mother to resume to sexual issues. As long as you are talking about the partner support issue, now I can see there is a contradiction between the science and what is happening at home, because the partner has been neglected. I'm trying to think that there is a need to work on a qualitative perspective to see what is happening within the families, because what I found is the partner has been abstained with the family, the influentials, the mother-in-laws, the mother of the one who has delivered. So there are a number of complex issues that need to be explored more, that who are supporting this sexual dysfunction to increase more. So I'm opting for qualitative methodology to ask why. Are they the ones, the family, I mean the male per se, or the other supporting family members within the group? Then coming to now, another question is Dr. Fatima, related to immediate postpartum isolation. I can see the effect is very low, and I'm trying if this is supposed to be applied, I think within healthcare facility, isn't it? So I'm trying. Maybe. Can you hear me? Yes. Yes. This is really amazing. I'm trying to think, and I'm asking myself, why is this happening? As well, there's a need to conduct qualitative and conducting via observation method, of which someone can be there and observe how the package has been ordered by the healthcare facility member. I think the providers, how are they delivering the message to the mother, or maybe there are medical issues that firstly has to be addressed to the mother. The IUCD in the session within 48 hours, or maybe there are cultural issues because we know we've got to visit them, and then maybe partner support, is it there, or maybe they are saying no, you don't have to use it. So to all of you, I think you have done with quantitative. I think there's a need to conduct via quantitative because no more issues. Thank you.
So the first one, how did you define toilet sharing in your study? And the second one is, what tool did you use for assessing the socioeconomic status?
Thank you all the presenters for the good work you have done. I don't have a question, but one comment to Dr. Fatima on PPOICD. So I'm happy that your first recommendation was to increase, to enhance the awareness and the practice in antenatal clinic. But one thing I would like to say also, the practice for weak clinicians in this method is the source of very low prevalence. Because we have surgeons, we have obstetricians, they know how to, they know that method, they do operations, they do cesarean sections, but awareness to do that PPOICD is the challenge. We are just forgetting to do that one. I remember, for example, last holiday, when we were in a holiday, I went to one of the health facilities, one of the senior surgeons who taught me a lot of procedures, and the patient was asking about family planning. So I canceled the patient, then we agreed to do PPOICD. I put 3 of them that week, and they just were wondering, how is it going? But those are senior surgeons, you see. So sometimes we are forgetting those methods. So I ask you to be the ambassador, advocate, to encourage this method, but for us clinicians, to increase awareness and practice of this method is safe, and for those who have hormonal issues, there is COPA IUCD, which is also very good in the range of 10 years, is safe and it can help our patients. So thank you, and I would like to recommend that. Thank you.
Thank you very much to all the presenters for the good presentations. I have comment and question to Dr. Tarsila, Rahia, and Dr. Salama. Starting with Dr. Rahia, first, thank you for your work that it's giving us another reason as to why we should continue keeping girl children in schools, because we've seen in your study that women who are educated had higher odds of having effective breastfeeding technique. So that's just a comment. But I wanted to ask, for you to conclude that almost 50% had good attachment, almost a good percent also had good positioning, how often were you observing them, and were you observing them in what environment? Because many at times when you go to the hospital, when a woman goes to the hospital, carries herself preparing to breastfeed well in front of the people, in front of the healthcare practitioners. But when you're at home, and for instance, if a child is older, a woman could be doing something else, yet releasing the breast for a baby to breastfeed. So I wanted to know, how did you observe that? And for Dr. Tarsila, thank you for your work. I wanted to ask now, what's your recommendation for the parents? Because now there's a lot being said about increasing knowledge, people to be aware of autism, and management and diagnosis for the children. But you have told us that it's bringing substantial mental health disturbances to the parents. So would you recommend family-based care, or what from your study can you recommend for that? And for Dr. Salama, all your recommendations and risk factors seems to be those that we have known since time immemorial for the risk factors and determinants for diarrhea. What new could we learn from your study so that we stop talking about diarrhea in 2023?
Thank you, presenters, and thank you for the last one who made the comment and asked a question. You preempted my two questions, and I'm adding another one to Tarsila. Before to Tarsila, to Laya, you mentioned that education has higher odds compared to others about the effectiveness of breastfeeding. But have you thought about the rural and the urban relationship? Because those who are coming from the rural areas, our mom put us well and the things works better. So what happened? That's one. But also I would like to ask you to Tarsila. My question is on your methodology. I don't know, how did you qualify this study to be mixed method? Which one informs the other? Because I've seen that you had a qualitative, but in the bigger part you discussed the qualitative part. So was it sequential? Was it concurrent? Which informs the other method, and which one was the denominant of the study?
Thank you for the questions. I think we have 8 questions, and let them respond. And I don't know, we're remaining with 5 minutes. So let them respond, and then we'll see if we have time for more questions. Who wants to start?
Well, to respond to the question asked from the first respondent about the toilet sharing, how we define toilet sharing. So we start with the definition of household first. We define a household where a household stands for a combination or group of people who are under the same provider. So that is one household. So when we talk about sharing of household, it means that there is more than one family who are using one toilet or a single toilet. That is how we define toilet sharing. So, and as for the economic status, how we identify economic status, we identify economic status through analysis, the wealth index, through wealth index, which we identify it by the conducting principal component analysis on the analysis stage, where we use simple data or routine available data, like household structure or household building materials, possession of simple radio, TV, fridge, electricity, or the type of power they are using. So we take data from that small available routine data, and then we conduct the principal component analysis to obtain the wealth index. That's how we assess economic status. And for the last respondent, what new we can learn from this, since it is already known for centuries, we can say. Yes, it is known, and there is a lot of intervention done currently, a lot of effort, a lot of strategy, but still we have the same problem. So this gives a chance for future research to try to unfold the unfolded situation there. So it is us, the duty of us as a researcher, to go and try where is the gap after all this effort, after all this awareness of the situation. So that's what I can say. Thank you.
Or should I start?
Thank you very much. Mine seems like a recommendation rather than a question. I quite agree with you, madam, that in the future research, maybe the methodological type should be more of the qualitative as to get the accurate data. But also with the observation in your previous studies that you observed the so-called Kubemenda, maybe this is just the misconception that has been there quite a long time, but I think postpartum, as the Madam Chairperson said, that a woman can just resume sex as far as she needs, regardless of the time period postpartum.
Okay, thank you very much for the question. I have two questions to answer. So the first question was about the environment that we use to assess these lactating mothers. So first we recruited mothers from postnatal ward, and there was a privacy for each mother. Everyone was like, we could take like 5 minutes, and there was a good privacy between each individual assessment. So I hope I answer your question. So the other question about the educational level, we have higher odds of practicing effective breastfeeding technique. Yeah, we, of course, yes, we could have think of urban and or rural areas, but residency was not among the factors that I was looking for. But even those who live in rural areas, maybe there are some there who have been educated. Not all of them, they are not educated. And also about education level to have higher odds, maybe because they have the chances of searching information from from medias, and maybe reading to any other sources in order to have this information about effective breastfeeding technique compared to those who does not have any educational level. So.
Okay, thank you for the questions and the comments. So starting with Dr. Gertrude's question, yes, my second recommendation was to have family-centered services. So we believe these family-centered services will impart parents with skills to be able to take care of these children, especially to manage their behavioral challenges, which is the main problem that these parents have. And this will eventually reduce their level of stress, caretaking stress. So the quantitative, answering the last question, so the quantitative study forced the qualitative study. So after conducting a quantitative study and finding that these children, most of them had behavioral disorders, the first comorbid, wanted to know how do their parents fare, how are their experiences. Yes, it might seem like it was dominating the quantitative, but it came after the quantitative study. And so the last question, I think Dr. Ngarina asked me a question first. So she wanted to know if if autism can be detected intrauterine. So I'm sorry to say no. Yeah, so but there are syndromes that if a child is born with, they increase the risk of a child developing autism. And some studies which have been done also shows that prematurity also increases the risk of a child having autism spectrum disorder.
Okay, thank you. So regarding my comments and questions, I just wanted to address on the question that I was asked on why the uptake was low. So that was not part of my study, but now that we have done a quantitative study and seen that the uptake is actually still low, we need to go ahead and do more qualitative studies on the part of providers, but also on the part of clients to see what is the reason that they don't uptake this method. But also during my data collection, I did realize that most of these clients do not know about the postpartum IUCD. They might know of IUCD as a method of contraception, but the fact that it can be put within 48 hours of delivery, very few people knew about that. So yeah, probably effective counseling could be a factor that is hindering this and other misconceptions. Thank you.
So, only one question, a burning one, because we have, the next session is just about to start. Any burning question? Okay, Dr. Phineas, our boss.
Thank you, Madam Chair. I just commend the presenters for the nice topics. They are very important in the area of reproductive, maternal, newborn, and child health. Just a comment and a question for the presenter, was presented on effective breastfeeding, Dr. Raya. It's very surprising that a quite number of women do not know how to breastfeed effectively. And this information is very important for us because not knowing how to breastfeed has a lot of implication in the growing of the newborn. I've just seen some disconnection between the title and the recommendation. The title was how to effectively breastfeed, and the recommendation was that the healthcare workers should support postpartum mothers to effectively breastfeed. We do understand that women will breastfeed well at home without the presence of healthcare workers. So the task of healthcare workers should be to teach the women how to breastfeed. That should be the proper recommendation. And remember, the study was not about finding whether women do know how to breastfeed. So there's some disconnection between the recommendation and the title. Now, my question comes, these factors which are associated with the effective breastfeeding, the multiplicity and education, they are obvious because if one has given birth once, twice, she will obviously know how to breastfeed. And if someone has higher education, will obviously know how to breastfeed. These we call them the determinants of health. And your study was based on Aga Khan and Mnazimoja, which are quite different. They are of different levels, and even the clients who go there, they might have different education. May we know how many clients were from Aga Khan and how many clients, study participants were from Mnazimoja? Because this, if we find most of the participants, a large number coming from Aga Khan, it's very likely that they have implication on your results, because they are very likely to be more educated, they are very likely to be richer than the counterpart. So I would like to hear from you the ratio of study participants from the two sides. Thank you very much, Madam Chair.
Thank you very much for the comments. And about the question, how many have been recruited from Mnazimoja and how many recruited from Aga Khan? So in this study, we enrolled 435 lactating mothers were enrolled. So from Aga Khan, we had 200 participants, and at Mnazimoja, we have 235. But almost we took the same proportion because I took those numbers due to how many mothers are being give birth for a month. So because first I did survey on how many lactating mothers, how many pregnant women, like mothers, they give birth in a month, and then I did like subjective to like how many should I take from Mnazimoja and how many I took from Aga Khan. So it wasn't like I had to take this one like large sample size and this hospital large sample size. So my ment was to take the same proportion from Aga Khan and from Mnazimoja.
Thank you, Raya, for the response. Maybe you'll go and sit with Phineas and discuss you. He will teach you how to make it look better. I hope so. So thank you everyone for your participation, and maybe please clap for the presenters. Yeah. Asanteni sana, then we go to the next session. Thank you.
I'm also dealing with biological mechanism of aging process, but I'm happy when Edward met me at some point in time, we had to negotiate with some of these topics, and I'm happy that I was given this topic because I think it's one of the most important topics, not only among geriatricians, but also among general practitioners all over the world, and especially here in Africa. So, as I've said before, I'm also part of the trust, which is called Registered Trustees of Ultimate Family Healthcare. Mainly we're dealing with family health, and we are going to deal with this a little bit later. In my outline, I'm going to introduce the concept because probably something relatively new in this environment, and even in Europe anyway. It's also important for me to give a snapshot of what exactly is successful aging as compared to the usual aging process. And maybe the most important to us as scientists, why it matters, the controversies, because there are a lot of controversies in this topic as well. There's a lot of research needed. And also I may come up with some recommendations or direction in terms of research thinking. Well, introduction, let's go to the basics. I know this is something which is relatively new globally. To be fair, even the science of geriatrics, as you know, in most cases has been considered to be a branch of internal medicine. Well, that is correct to some extent, but as far as we are concerned, in the past 60 years, there have been a lot of research done, and right now it's evolving, just like the way at some point in time, pediatrics had to evolve out of internal medicine. So what's aging in a nutshell? It's just a time-related decline of both physiological function and reserves necessary for survival and fertility. We have to agree that when we're discussing these issues as medical doctors, as scientists, we have to refer to a lot of concepts from biological sciences. Why? Because we are part of the evolutionary process. So whether we like it or not, there are some phenomena that you'll have to undergo as part of nature. So this concept of aging was derived by Tom Kirkwood, sometimes in 1977. By then, some of us were not yet born. Kirkwood was of the opinion that aging is not an event that we normally characterize in geriatrics as people aged above 65 based on calendar time, but rather he defined aging as an evolutionary process. And therefore, I would wish this concept of aging to be regarded so, because I'm aware there are a lot of other definitions of aging, but I think for our talk today, this is the most important one that is still in use worldwide. As I've said before, aging should not be regarded as an event that happens after your 65th birthday, but rather as a process that is predetermined and somehow managed by both nature, by means of genetics, and nurture, by means of our environment. In my introduction as well, I would wish to emphasize on the variations, because most of the research we are currently doing worldwide, we normally present statistical summaries of mean and things like standard deviations, which are considered to be sine qua non worldwide for most of our research findings. However, for us to understand aging process per se, we need to consider variations as much as we are considering other statistical summaries. Why am I saying so? I decided to remove some of the slides so that we can all understand. In the past, we used to have people living, let's say, to 50s, 60s, and if you reach 70s, in the early modern age, people used to consider you as somehow very old. But as the left graph that I've put for you, which is quite vivid, in the past 50 years or so, the average life expectancy worldwide has gone up in all continents. What does it mean? We reached a point whereby those things that we used to believe to be accompanied by our internal circuitry in terms of our survival and fitness were proved to be wrong and illogical. So from a demographic point of view, we started experiencing a lot of changes in survival times among humans across all continents. And even the average life expectancy for the entire world, you could see it on the blue graph upstairs on the left, it also went up tremendously. We must have to understand that these graphs that I've shown it to you here, they're just summaries of what is happening in the world. Actually, what has been happening in the world. And also on the right side of the same left graph, those are projections. So as you can see, what we have seen in the past 60 years is also likely to change, and change in a positive way. As of December 1st, 2015, geriatricians had already concluded that somebody who will live 150 years was already born. And we are not sure who he or she is. It could be some of us here, it could be somebody else in Sri Lanka or in Argentina or wherever, but at least the cornerstone about this introductory part is to show you that probably what we used to believe as a limit for longevity is not necessarily logical from scientific point of view. And as a clinician, I normally like to see what happens to our patients. So on the right side, there's this graph that was actually part of the research findings by Raven back when I was just 2 years old. This publication went out and it was like the man of the day by then. So what was shown was the fact that if we are to consider this thing called glycation process, and we normally use this parameter almost incorrectly as clinicians to measure prognosis of diabetes, which is okay, But we normally forget that this is actually an aging marker per se, because the process of getting HbA1c involves a lot of non-enzymatic glycation process, and therefore at some point in time it measures not only the glucose load average in your blood, but also the aging process. So what was found back in 1985 by Raven and Raven was the fact that if you were to take average age for males and females, there's an average increase over time. And the conclusion was probably diabetes was an aging disease by then. We are going to see it later. Probably this was not factual. Okay, now there's another issue here which it's important before I start talking about successful aging. And apart from the definition of aging process, there are also other issues that we need to consider. There's this thing called usual aging, which is quite part of our literature nowadays, whereby it's just the normal age-related functional decline that are consistent with age-matched controls. These are things like growing of the hair. When you see somebody above 60, growing of the hair, we tend to associate it with normality. And the concept behind here has been coined as usual aging. Of course, we are aware there are a lot of variations because there are some people aged 20 and they have gray hair. So when it comes to successful aging, which is part of my talk today, it's actually derived out of outlier analysis. Why am I saying that? Because these are people undergoing process whereby they are completely outlying with respect to their age and sex matched controls. How? For instance, we all know that systolic blood pressure tends to rise with age, or at least with calendar time. And when you find somebody in his or her early 90s having a systolic blood pressure of around 115 millimeters of mercury, we normally tend to be surprised. Why? Because our medical education is centered about treating diseases and not appreciating nature. So we have already started seeing people whom we have decided to call them successful aged simply because they're very minimal to no functional decline over time compared to their age and sex matched controls. Does it matter? Probably yes. Does it matter to have been successful aged? Probably yes, especially for us who are dealing not only with clinics but also research. It gives us an impression that it's possible to extend longevity. In the past, we used to consider that human longevity is something constant, and maybe we can only increase life expectancy. But over time, we've come to realize both can go up. And as I've shown to you via graphs, data are there, which have shown that actually what we used to believe was probably not correct. So while we are considering whether it matters or not, it comes both from the clinical as well from the economics point of view, and even sociological for that matter. Because we have realized if we are to increase fitness to optimum level, probably we can forego what we are currently considering to be old age. And we are still doing a lot of research. I'm personally doing research in Dar es Salaam, having a cohort, which I've just synthesized. Probably next week we are going to send the protocol to NIMRI. And the whole essence is to come up with a proof of concept for clinical geriatrics with regard to the so-called successful aging. So we have started seeing some people even here in Dar es Salaam. For instance, our chair today, he's almost 80 years old, but his systolic blood pressure is less than mine. If you are to take Dr. Godfrey Swai's age and you take mine, it's in a ratio of almost 1:2. But he has maintained fitness, I don't know how, maybe nature, to the extent that things are going right. Some gray areas, which I think is my last slide anyway. We came up with some domains trying to show this concept of successful aging. It comes with 4 different areas, as I've mentioned, but all these areas are part of the gray areas at present, and especially this issue of spirituality, because currently we are collecting data on that, and it has shown to be inclusive and successful aging as a concept. Thank you very much. I think my time is over. If there are some questions, I don't know.
Maybe we can keep the questions up to end of the session, please. So we can have the next presentation will be online. And can you do
Hello to everyone. I am pleased to be here today to present a plenary session about the link between 2 main important topics that are neuronutrition and aging. In order to explain how specific nutrition and so nutrients acquired over time through the diet can positively influence the physiological process of aging. So, with this aim, first of all, let's go to define what is the aging process. Aging is a physiological process in the life of living being, and it is heterogeneous, with different rates in different people, with variations in all organs, even in the same individual. But sometimes age-related changes can cause transition in a pathological status. So the building blocks of organ and organisms are cells, and cellular aging drives force of organ and organism aging. There are a lot of aspects which characterize cellular aging, that is like epigenetic changes, genetic instability, telomere shortening, nuclear body disorders, cell cycle arrest, mitochondrial malfunction, signaling pathway alterations, or also disorders in deregulation of nutrient sensing and signaling. And obviously also the brain is subjected to the aging process. Brain acts like a supreme commanding center of the human body. The central nervous system through the peripheral nervous system tracts blood vessels and innervates all organs. So, neural control is everywhere. Aging process induce changes in the brain at biochemical, cellular and structural and functional levels, with the possibility to induce the risks of a range of neurodegenerative diseases. And brain aging is also characterized by learning and memory decline, and environmental factors such as stress, diet, socioeconomical status, smoking, alcoholism, can produce alterations of function in cognition status later in the life. And in support of this, in recent life, the increase of population and life expectancy have determined the manifestations of age-related neurodegenerative disease and dementia. So, we ask what kind of solution we can assume. Maybe improve the lifestyle. And in the context of lifestyle, including exercise, wellness, and relaxing, the neuronutrition appears to be essential and needful. So let's define what is neuronutrition. The neuronutrition is an approach of nutrition aimed to reach mental wellness in all forms, maintaining as far as possible every neurocognitive function. Neuronutrition looks at brain and its needs. In this window, a right diet style appears like strategy to improve cognitive abilities, preventing brain damage. Of course, the combination of benefic foods is the key rather than the choice of the introduction of a single kind of them. In this context of healthy brain over time of aging period, the right use of nutrition is a promising way to reduce age-related pathologies, such as dementia and neurodegeneration, with a preventive role against the onset of alterated states of mind. There are many nutrients which are useful for this goal. We mention vitamins, flavonoids, long-chain omega-3 fatty acids exert a potential benefit for cognitive function. As cited before, the most protective effect is generated by the use of specified multi-nutrients approach. The class of healthy nutrients obviously includes vitamins B, in particular folates, but not B12, are associated with a lower risk of dementia or Alzheimer's disease. That is true when the levels of homocysteine are elevated. Folic acid reduces the plasmatic concentration of a sulfur amino acid containing the sulfurous, which is generated by enzymatic processing of the methionine and the accumulation and the transformation of it in the blood is correlated to the onset of cardiological alterations and stroke, as well as dementia and brain disorders, like Alzheimer's. Indeed, the administration of folic acid has showed a slow rate of memory decline. But in general, we also remember that folates and B12 and B6 are important to reduce the brain atrophy, and B12 is very important for the normal brain development and for its function in terms of performances. Where we found this kind of vitamins? We found the folic acid in the vegetables and lemon, B6 in avocado, banana, beef and vegetables, pork and cereals, and then B12 in meat, fish, eggs, and also in the milk. Always is important to consider the multi-nutrients approach. Therefore, combinations of different components such as fatty acids, vitamins A, E, and D, and carotenoids are candidates to reduce the long-term risk of dementia. Indeed, when we eat bad, with junk food full of saturated fats, accompanied by low concentration and provision of carotenoids, polysaturated fatty acids, and vitamin D, we are exposed to 3.7-fold higher risk of dementia development. We create, in this case, the condition of dysfunctions, and it's very important, so know that junk food have deleterious effects, and they are prominent in the context of a poor healthy nutrients in the body. Lipid diet is an innovative approach based on the use of a multi-nutrient cocktail, including 11 nutrients like vitamin E, B6, B9, B12, selenium, and phospholipids. It showed to promote brain health in prodromic patients of Alzheimer's disease after a time of 24 months. Benefits were related to improvement in cognitive performance, less cognitive decline, and a daily normal function. Interestingly, this kind of approach can be a proof that a specific intervention on extended period based on the introduction of combined nutrients could be a strategy to slow down the progression of mental diseases like the Alzheimer's disease. Mediterranean diet is another model of nutrition, the most famous, and it is based on a pyramid of health, in which we can notice at the base of the pyramid the most important foods that for us, for our healthy, and as we go up, we look at foods that are less important and should be acquired in a limited way. The main foods are vegetables, fruits, bread, cereals, legumes, and seeds. Low to moderate, there is the use of fish, red meat, poultry, and wine. And the main source of fat should be oil. The Mediterranean diet is related to lower rates and lower risks of cognitive impairments, together with higher scores of global cognitive performances. Beyond the diet style that we have described before, there's another important aspect in the field of nutrition, and this is the gut microbiome system. That is a microbiome of a community of microorganisms that naturally live in our gut and they are able to generate signals directly to the brain through the enteric nervous system. But during aging, there are many alterations of this system, such as aberrant microbiome resilience, the loss of homeostatic regulation of its diversity, alteration in the enrichment of pathogenic bacterial species, rearrangements in saccharolytic and proteolytic microbial populations, together with a reduction in short-chain fatty acid producers. All the aspects that we have showed before related to aging alterations of gut microbiome can be strictly related to accelerate brain aging and decline. In this window, the role of prebiotics, probiotics, and postbiotics is essential. In fact, they are all associated to neuroprotective functions. Prebiotics are substrates that are selectively used by host microorganisms to confer a health benefit. Prebiotics include dietary fibers that facilitate the growth of beneficial gut bacteria, and in rodents were found effects associated with the prevention of post-inflammation anxiety and a better cognitive flexibility. Probiotics, they are live microorganisms able to confer positive health effects to the host, including growth and activity of specific bacterial species. And the postbiotics are any soluble factor which derives from the metabolic activity of live bacteria or any released molecule able to provide health benefits with a direct or indirect mechanisms. So our conclusions evidence that there are rules of good nutrition that can be the difference. The Mediterranean diet is always a good choice, and our microbiota is able to influence the benefits of nutrition through prebiotics, postbiotics, and the introduction of probiotics. So, eating with the mind to have a good mind. To conclude, I want to say thank you to my lab and my PI, Professor Vincenzo Leonetti, who supports me in my work. And I want to say thank you to Scuola Superiore Sant'Anna, a prestigious school, one of the best in Italy and Europe, and the Hospital Agostino Gemelli in Capobasso Molise, where I work like adjunct professor, and I have the opportunity to teach the science to very special young students. And a special thank you for listening to me, to the audience, and a special thank you to MUHAS conference for this kind of opportunity to be a speaker today in this beautiful context. Hello to everyone. I am pleased
use of. We will look for Tanzanian diet similar to the advantages of the Mediterranean diet. If there are any questions, we should make sure that we get in touch with you. So, if we can get online with you, we make arrangement that the questions will be posted and they can later on appear in our scientific proceeding document. Thank you so much, Professor. Has not anybody got a lighter, the pointer? You have a pointer? Aye. If you don't mind, we can all look at the PowerPoint while I sit down, please. Oh, thank you very much. As I told you, I'm excited to be with you. And someone asking, how do you get fit? But just forget about aging, eh? And then you're off aging. So, the topic on ethical and policy dilemma and what models of care can be available to aging. This is a very broad subject. Eh? But let's get the definition first. Let's get definitions. So the outline of the presentation will look at what are the definitions. As you say, people have been said, there are many definitions of aging. So to just narrow the subject, we'll have some definition. And I know, please, you might find some spelling mistakes, don't care about that one. But we will be looking at population pyramids. They provide us information on aging, actually, in a very dynamic way, in a very real-time way. But I would like to compare our pyramids with our colleagues or friends in Sweden. And then we shall further look into aging, health aging. We'll define it. And then the population pyramids of Tanzania and with other countries. But we shall see how was our pyramid 1961 and how is it today. We had the last census last year. And then we shall look into the issue of nutrition. I'm happy Professor Maria did talk of nutrition and health and how they work together to really provide us this aging, healthy aging. And then we look into area of working force and population, and finally we shall have interpretation, ethical and policy interpretations. Next slide. Oh, this is. So, aging is gradual and is a continuous process of nature. And that change begins very early in life, and maybe also before life. And then what is healthy aging is another process now of you have to be active, proactive if you are doing healthy. You have to maintain functional abilities, memory, physical, even social. And then this will enable you to live well in older ages. And let's describe who is it is more in keeping with the vocabulary now to call old people. People are now they like to be called senior citizens if you are above 65. And I've been asked to look at models of healthcare for aging. And the definition is, it is an integrated, it's a continuum of comprehensive lifelong services. And this need to operate at the personal level, at the family level, and at the social level to be really healthcare model. And then what is dilemma? When you talk of ethical dilemma, and this is more medical ethical dilemma, that you are in a situation and you have several possible outcomes, and each of these action breaches some otherwise binding moral responsibility. It can be family, it can be professional. So you are not able to make a decision. You are in between. So this, I said ethical. There is also politics in ethics, in economics, in nutrition. So, but more I was thinking of medical. And now we have political dilemma is a situation of regulating the state's exercise of power on two connected problems given, it's not, okay, given official learning, because government takes a position, and on that position they exercise power, and sometimes there is conflict of deciding. But either ethical dilemma and political dilemma, they all operate on good governance. Whether you are a doctor or you are a politician, then you are responsible to conduct public affairs and manage public resources for the development of all persons. So let's take this definition along, and let's look at the aging population pyramids of Tanzania and Sweden in 1923. And this is from our recent census, but these are available online, really. You can see a difference. So I would like you to appreciate this pyramid and this rectangle, this skyscraper, and this. We are talking of 2023 in the same planet, in the same world. But our population is that way, and this one. What does this show? Lots of people dying as they grow over time, okay? In this one, deaths are very minimal. Yeah? We are 2023. So a lot of people are dying here. Who is really responsible? Politicians or medical? You'll tell me later. Here also. So it's possible to stop people dying, and then we can have this one. And who is responsible? Politicians or medics? These are the ethical and the political questions we'll be carrying, but we shall use population pyramids to explain a few things. And it is, to say earlier, it's the responsibility of medics, professionals, to actually transform from this death to this model. Okay, so let's see what is the demography of, what's the difference? We are 6 times more than Sweden. Our life expectancy is 66, they are 83. Fertility is very high, almost how many, 3-4 times. Birth rate of fertility is high, and then of course it's low in Sweden. Crude birth rate is almost the same. Human Development Index, talking about the political function, we are almost half. How innovative are we? Yeah, if we rank ourselves for 128 countries, we have position number almost near to 100. Sweden is number 3 in the world. Corruption, if you take an index of if you take 100 as the score, our score is 38. And that one of, so remember, our pyramid is compatible with these figures, and the Sweden pyramid is compatible with, this is a high score. They don't like corruption there. How fragile are we? Index out of 120, we are very close to this figure. They are very far. Competitiveness ranking out of 141 countries, we are 117, Sweden is 8. The right information, how much do we rank out of 180? 124, 40. Human capital rank, capital. There we are. How about doing business? If we mean business, how much, what will be our rank? 141, Sweden is up there. So that population pyramid is compatible with these figures. What is the GDP per capita? 1,100. Oh, this is how many times? Please. 5 times, 50. 50, yeah. How about debt per capita? This is our debt. Sweden, but they have something up there. Expenditure per capita, 196. How much factors in here? 13 times and more or so. How about health expenditure per capita? They spend almost twice as much. Education, 33 in terms of dollars, they spend 4,000. And then how much do we spend in finding out our problems? 0.5% of capita per capita, and then they spend almost that is about 7 times. So I think I can go back to the pyramids, but the pyramids you saw, the figures responsible. Let's look into recent events. COVID, let's say, we had 43,000 confirmed cases out of a population of 60. So this is very low testing. These figures are on the website. Sweden with 10, almost 1/3 could be tested. Doses in millions. Yeah, these were the doses for 63 million, this was for 10 million, twice as much. Deaths per million, we had 13, they had 2,000. But of course, are you sure these figures are good? Okay. Stunting, I couldn't get the figures for stunting, but we have stunting below 5 years of 31%. And we have stunting of adolescent up to 19 of 25%. Okay? This is, we shall talk about this more in details. Maternal mortality rate is still very high. It goes up and down. Sweden, 5 per 100,000. And the anemia in women, 13.6. Anemia in children is about 65% or so. Do you have a pediatrician? So how are we moving from 1961 to 2023? Have we changed? Are we interested to change our population pyramid? This was 1961 at independence. And this is the pyramid. I mean, we are dying as we used to die, okay? So let's go and Sweden. How was it in Sweden? This is what it was in Sweden. They have improved. They were 61, we got independence, okay? And then they have improved. They have become narrow anyway, okay? But you remember the first one. Remember these pyramids. Let me go down. So how about our neighbors, Burundi? This is 61. They seem to, something is happening at the bottom, in Burundi. Huh? What is that? Someone is happening in Burundi, something is happening at the bottom. But not in our, if you remember that one. Let's take up another country. This is Nigeria. Big country with a lot of people, a lot of petroleum, everything. So these are the aging. It gives us how are they aging, because 0 to 4 is here, and then 150 is up there. So Nigeria has not made a lot of difference over the past 62 years or so. It's okay? Ghana had a problem here. Quite a number of people died here. But Ghana is coming up, It's putting up a foundation. One of the things to notice is that the foundation starts from the bottom upwards, okay? The foundation for longevity starts downwards, upwards. So that is Ghana. Botswana, 61, they were almost like us, but they are coming. They are building up a foundation away from the pyramids. They are now going to have skyscraper. Who is it? Algeria. Algeria also, in the African, we are still in the African continent. They had this problem like ours. They changed, actually, into a new mode of aging. And then they are building up similar to that one in Sweden. It's coming close to, who are this? Indonesia has tried very much, From similar to us, is almost really going up. But you can see things you can build from the bottom, and this is the bottom part is here. This one is here. So actually from the bottom, you can build up. We'll talk more about that. Ghana, China. A big trading friend. They were almost like us. They are now building up like the data we had in Ghana. Cuba, it's not a very rich country. I like their data. They were like this at independence. Now they are actually like Sweden, very close. And how about the world? If you take all the people in the world, the world had a better pyramid in 61, but the pyramid now around the world is actually going towards Sweden. Do you remember Tanzanian pyramid? Please remember as we go along. So what are the lessons that if healthy aging, when we really healthy age, is a decision. It's actually an ethical and political decision of leaving no one behind. You start from 0 to 1 and you go up to the end of life. And That end of life, most of these things, some people are going right above 100 years. Because healthy living begins very early in life, and then it gets old, and it's over the entire lifespan, and you have a privilege, everybody. If you don't live anybody, everybody can get to 100 years. And that process starts at the bottom. And then it goes on. Once all the pyramids I've seen of countries, once they start, if you follow up, they're still going up. If we have not started in Tanzania of building a skyscraper, we like pyramids. And then there is a lot of premature death that can be prevented. This is an ethical issue, and it is for us to tell the politician how to prevent. We have just to acquire, define healthy aging practice and do it. So if you look into the latest, what is really killing 0 to 4? Okay, I just 2 things: infection, number 2, infection, number 3, diarrhea with no dehydration. I don't know whether it's infection, but this is the data from the minister's speech in Parliament. And then if you are above 5 years, still infection. This is just malaria. Okay. Number 4, for children, infection. Changing a little bit here. This is also none. Okay. And then you go up for children, infection. Other non-infectious GIT, only number 7. But on the adult side, infection, diabetes, intestinal worms, very high. They eat, and you eat, you have to compete with them. So I think infection is a problem. If you can control infection, then at 0.4, you'll be able to start building the pyramid upwards. So this is what I was taught in medical school long time ago, in 75 or so, that undernutrition will give you infection. Yeah? This is the vicious cycle. And then it will give you mortality. And then poverty. Okay? You remember the parameters of Sweden and Tanzania. Sweden is rich. And we just call ourselves politely low-income country. So infection is very closely linked to undernutrition. And if you have high mortality, you will be poor. So you have to get really out of this. So how much of infection we've been in 1991, stunting was 50, and it's now 31. And how many years from 1991? 30 years, right? If we are 30 here, and SDG goals are only 5 years to come, are we going to really have 0? Are we? No way. So there is this mutuality: health, disease, malnutrition, infection, mortality, and these are really central to aging. Either in Sweden or anywhere is central. And then our stunting for children under 5, 34, 31, almost 32, anemia 65. These are preventable, you know. Okay? And this is the foundation. Under 5 is the foundation on which you have to build the rest of the pyramid. Now, we don't very much see, if you go to the literature, we don't see stunting. Even on the streets, only the acute conditions come to hospital. But stunting gives you mental and cognitive disability, okay? And once you are mentally, over your entire lifespan, is this worse than dementia of old age? And then, if parents are all stunted, the child actually will be also stunted and will have this mental and cognitive disability. So that this mental brain damage at 30%. If the brain is damaged plus anemia, I not read that medicine, what you can have. I have not done the study. So healthy aging cannot go the Swedish way if you have stunting. Actually, that is modern. That's what we want to be. So if you go back, if you have, and you go back. Not this one. Yeah. Maybe I'll just go. So, okay. So SDG 1 is poverty. Yeah? We cannot overcome poverty. 2 is hunger. We already stunted 30% anemia, micronutrient deficiency. 3, health and well-being. You can't be here because stunting here will not let you have health and well-being. Stunting will not have you that cognitive capacity. Stunting at 30, you can get competitive competitiveness will not be there, okay? So SDG is compromised for not handling stunting and anemia, and all these are preventable, yeah? So, so let's go to the other thing we want to discuss is about the workforce. If you superimpose this picture is in the the census report on aging. This is our pyramid, and this is the Swedish pyramid. This is the aging population, okay? You see, you need this workforce to give you the money and the economy to support old people and young people. But this type of structure is actually stealing these people. So our pyramid is not supported by quite a number of people who are dying at this age. And also there are people here which actually have the memory. The aging memory is here. They will tell these people and these people how to get here. You need these people here to say how you can get up there. So our workforce in terms of quantity is actually compromised. So this is Tanzania. Let's go back to Tanzania and look at our workforce. It's 54% of the population. This is 54%, this is the workforce, above 65, and this is the under 15. We define workforce to be this population is 54%. But if you put on the factor of stunting, because you need people who can think digitally. If you reduce the 54 by 38%, these are actually the productive people taking care of under 15 and taking care of above 15. If you go to statistics, they will tell you this is the figure. Oh, sorry. If you go to statistics, they'll just give you, but I'm talking of the mental capacity. A workforce must have really the capacity to deliver technical things. And we are going into the digital world. So we need a workforce, not a stunted workforce. Yeah. So, just to wind up, where are we? First of all, we really have to, is it clear here? Okay. We have to understand what are the health needs of the people. And to know this one, you really have to review and assess health needs of the people in participatory way. 2, we now have a health policy from the assessment. And then we need to have a health research agenda to take care of what is going here. Then we have a strategy, how we are going to build up this aging health aging. And then we start implementation science for each strategy. And we see, are they working or not working? We have to keep monitoring. And then we improve. We come and talk to the people. Are we improving? Are we meeting health needs of the people? So so what is the dilemma now? To just complete is that if you go through the stages, I put them on the left, and under good governance, we have the ethics dilemma and the political dilemma. Under ethics, you are the ones who provide services, you do research, you do training. And then you must understand under policy, you have the people to decide and you have the government to decide. So do we know health needs of our people? Our coverage is 54%. So we don't know health needs of 46%. Do you really know research needs of the people? So I put a plus and minus. These are the areas that we have to clear so that this one should be about 80 as we go to Sweden, plus. We know all these things. Have you reviewed the needs of the people? Not yet. Have you done research? Do you conduct enough research to review and assess needs of the people, needs of services, needs of training? Are we reviewing? We have the national policy of 207. Does it meet services? Does it specify about agenda, training, and so forth? And then, do you have a national research agenda for services, for research itself, for training? Do you have a health strategies? We have for services. But do you have a strategy for research? A national one for training? And then do we have, how much of implementation research are we doing to make sure that what our strategies are really doing that one? And then in terms of monitoring evaluation, it must be real time. There is no way we can really go on paper. So research has to come up with. Services are partly not digital. Is research digital? Is training digital? Are people in health digital? Government? How is our monitoring system? How is our evaluation system? Do we have reports of what we do on the research? So overall, looking at it, you find that we are deficient in research. So to summarize, sorry. Last but one, please. Ile summary. Aha, okay. Here. So there is no shortcut. We have just to do research to inform ethical and policy dilemma. And both of these are really compromising good governance. Now, the model for health aging is a continuous and growing cycle. From step number 1 up to step number 4. So you have to define and ask and find them. And then there is no shortcut. You can't jump at any stage and say, okay, we are now doing a research on old people and forgetting about children. So finally, to conclude this, we have to invest and do local research. Or we have to all die. This is the option. I mean, this is really the issue. Do we do research or we die? And there is no shortcut. We know 80 to 90% of people's health and nutrition needs can be met at the community. We are not doing it, and we have the pyramid after 63 years of independence. And now, aging approach, it really embraces primary health care, One Health thinking, all SDGs, and universal health coverage. If you can start research at the local, take care of 70, then we are on the road to. And then health aging approach cycle is a way of leaving no one behind up to 100 years. So thank you very much, colleagues. Okay.
Thank you so much, Dr. Swai, for an educative session. So may I welcome the presenters to the stage for questions and comments. I'm not sure if those people who are giving their presentation online are still online. Can you check on them? Professor Diana? Okay. Dr. Maria, can you follow? Okay. Okay. Thank you so much. So after the 4 presentations, may I welcome the audience for questions and comments. Dr. Kija.
Yes, thank you very much. My name is Edward Kija. And first I want to thank all the presenters for wonderful and very educative talks. But I have a few questions. The first question goes to Professor Diana. It was interesting the study that you presented, the Leiden study, that you looked at people who lived long and then you compared with their respective offsprings. I was just wondering whether you looked into those two groups, whether you looked, number one, into their fitness level, like how much exercise between the people who live long and those their controls, whether they were similar or not. And the second question, whether there was any studies that looked into their genetics, whether there was any difference, whether there was any gene which was found. My second question, I think, goes to maybe Kelvin or Diana. You may take that. You spoke about a very interesting area of calendar age. That, you know, someone might be calendar age 30 years, but probably actual age may be 50, or maybe the liver might be 20 years, but the kidneys are 30 years. So I was just wondering, is there a mechanism or a tool where we could actually measure in someone and compare their calendar age vis-a-vis, I'm just using this term, I'm not sure whether it's an actual term or not, vis-a-vis their aging age or their actual age. And then my third question goes to Professor Maria Bola. She talked about interesting area on the gut microbiome and how the gut microbiome can improve the cognitive well-being. And there's that progressive decline on the gut microbiome. So I was just wondering whether there is any data or any studies which have been done trying to maintain that gut microbiome and see if there will be any effect or any influence on the longevity of people. Thank you.
Okay, I think we welcome first. Okay, maybe Professor Balanja.
Thank you. So long as the mic is here, can go ahead and take advantage. A question to Dr. Swai. Can you address the chicken and egg situation as we're trying to change the shape of the pyramid? Can you address the chicken and egg situation in terms of, giving health care, making sure these babies survive, and addressing the needs once they are alive? Because let's say in Tanzania now we have 2 million babies who are born every year. If they have to survive, all of them, then we'll need how many schools, how many healthcare facilities? Should we address the healthcare issues and school and everything first, and then, or should we just do the immunization and nutrition, and then once they are out there, and then think about what we want to do? Because I think if you remember 10 or so years back, that during Jakaya Kikwete times, the Prime Minister had this move to say, every ward you have to have more primary schools and more, it was like an ad hoc issue. Can we think about those things and, have a more multi-sectoral approach to these things, not just health? Thank you.
Yeah. Thank you, Professor Balanja. Professor Simba.
Well, I want to answer the question about the microbiome. Obviously, the microbiome is composed by probiotics that are a community of benefic bacteria that confer benefic effects on our body. And how the answer is how the microbiome can contribute to give benefic effects to our mind. Of course, in terms of postbiotics, that meaning that there are these microbiome with probiotics which produce soluble components and molecules that are able to stimulate the central nervous system to release neurotransmitters that are positive effects on our mind. For example, like neurotransmitters, we can cite the dopamine, for example, that is important for our attention, and also the release of the serotonin that is important for the happiness. So against also the risk of the onset of depression or other feelings that are related to sadness.
Okay, thank you, Dr. Kija. Thank you, Professor Maria. But may I say something about microbiome? There was a study that was being published in the British Medical Journal that was looking around the rates, the level, the role of microbiome expressed in terms of levels of intestine alkaline phosphatase. And its contribution in causing diabetes or preventing diabetes. So the science generally was there are these guts, the microbiomes that are pathogenic and the protective ones. And those which are protective were known generally to be lower in among people with diabetes. And presence of this protective that are known as sodium butyrate producing bacteria is associated with increased intestine alkaline phosphatase, which is produced by our own gut. And this intestine alkaline phosphatase is being released in the system, and it tends to neutralize different compounds of the bacteria that are, let's say, the cell wall components of bacteria, which are usually pro-inflammatory. So if you're having low level of this good or the sodium butyrate producing bacteria, you're going to have pro-inflammatory markers which will give you low-grade inflammation, which is the culprit or the ground of almost all known chronic diseases, ranging from diabetes, dementia, and many others. So the role of the probiotics, prebiotics is to increase this sodium butyrate producing bacteria, which neutralize this underlying inflammation, which is a culprit for all chronic diseases. So may I welcome Professor Simba for the question. Yes.
Shall I give answer on the previous questions about the Leiden longevity study, or?
It's okay. Okay, you can proceed.
Okay?
You can proceed. We can hear you.
Okay, so I think the questions were very good, I must say. So the first question, I think, was about the influence of exercise. And I think that's a very good question because, of course, if you compare two different groups, there may be lots of, especially if the numbers are small, there may be lots of differences in behavior, such as smoking or exercise, that may explain for the observed differences. And in the case of longevity, it's always very difficult to find the right control groups. So the way we kind of try to address that challenge was to basically, so our premises were that if longevity is to some extent genetically determined, then those favorable genes of people who really have proven to become long-lived, like they were in the 90s, those genes should be transmitted to their offspring, who are around 60, 65 years of age at the moment that we included them. So the offspring would then be predisposed for longevity, so they had a higher chance to have inherited those favorable genes. And then we took the current living partners of the offspring group as a control group, because they, it's of course not perfect, but most of them share the adult living environment, and so they have the same socioeconomic status, and often they are comparable with respect to exercise, smoking. We actually tested food intake based on food frequency questionnaires and 24-hour recalls. We assessed smoking, we assessed activity based on questionnaires, but also via accelerometry. And indeed, the two groups that we compared were shown not to differ in any of those environmental exposures, like exercise, smoking, or socioeconomic status. So I think a very good question, but we did indeed check for that. And then I think the other question was about the genes. And this too has been analyzed, and I think there's been a lot of research done on, what kind of genes are implicated in longevity in humans. And the ones that most frequently popped up were FOXO3, which is actually part of this insulin IGF-1 signaling cascade of this neuroendocrine network that was also shown to lead to longevity in the fruit fly and in the nematode roundworm. And also ApoE, which is involved in lipid metabolism. So those are the two main hits that have been discovered to be associated with improved old age survival and lifespan. And then I think regarding the last question about biological age, I think there too there are a lot of developments going on. Because it's indeed a very, valid question, how does calendar age relate to biological age? And there are a lot of tools being developed, for example, based on methylation, which is called the epigenetic clock, but also based on all sorts of metabolites. There's this metabolomics platform, which is actually enriched in particles involved in lipoprotein metabolism. And Eline Slagboom, also from the group who works on the Leiden longevity study in the Netherlands, they have developed a kind of score which is called the metabolo age score, and that's maybe based on some of those metabolomics markers, which were also shown to be different between people from long-lived families and controls, and that were also nicely shown to correlate with measures of biological age. And personally, I think that also even more simpler measures, like, for example, insulin sensitivity or circulating levels of glucose, they also may be indicative of somebody's general health and biological age. So I hope that answers some of the questions that were raised.
Thank you. I give the mic to Professor Simba for his question. Okay, you're welcome, Dr. Swai, as I'm giving the mic to Professor Simba.
Thank you. Thank you, Professor, for the chicken and the egg question. There is an answer, and we have the answer. When we got independence in 1961, we used to say that we have three enemies: diseases, poverty, and ignorance. And this went on for almost 30 years. But if you have a shilling to invest in development, would you send it to diseases? Would we send it to ignorance or to poverty? Actually, the answer is that stunting was the nutritional problem. And it is stunting that caused poverty, if you go into that vicious cycle, okay? And that is stunting already had eaten 30% of your brain in the population. So that really gave us ignorance. And that is carried over entire lifespan. So Cuba recognized, we got the independence in 1961, and Cuba was independent in 1959. Cuba pyramid is the same as like that one of Sweden. And they did not spend a lot of resources like Sweden is spending now, almost a quarter. But they went to the people. They identified people's needs. What are the people's needs? We have said we just have to feed now. Tanzania is every type of food, protein, vitamin, more than the Mediterranean region. But who is to say what to be eaten? It is the medics. And it is the medical ethics that have failed. How have they failed? Because the politicians don't know how to do and how to do it actually. You are the ones who are supposed, we are the ones supposed to come up with this is what to be done. What we need is to do research. But you cannot develop in research with 0.5 per capita dollar. No way. If your motto is services, research and training, if you have 3 shillings, one should go to research, one should go to services, one should go to teaching. Now, our referral system is not operating, so that you can no longer capture or take care of 80–90% of people who have needs in the community. So anybody can come to Muhimbili. We do not have an organized health system. Why? Nobody knows how to do it, because we don't have a research agenda, we don't have a national health research policy that specifies what to be done. Who is to do that? A politician. It is the medics who have to do. How do they do that? They have to do research. And how to do that? They have to go and do research for people's needs. So this change of mind, I'm very happy that Lancet has taken a lot of, and the Commission now influence global health to think of local research in developing countries. I think you remember about the 10% disproportion, that 90% of research funding goes to 10% of burden of disease. From the 1970, it has not changed. In fact, it has become less. So, professor is supposed to be at the community, not at the university. To say what should be done so that we have this skyscraper, not the old pyramid. So Cuba made that decision, and they are now a different country. They can now develop. But we shall never develop. Now it takes 60 years to make this transformation. So how do we start? It is the academic, it is the high-top professionals that have to change mind on the strength of figures on the ground. So I think, Professor, I've partly been able to answer your question. It is very difficult to change mindset after 80, but in front of figures, it is very possible to. So the starting point is really nutrition at the community and primary health care, and then there are now a lot of models that are not prescriptive, but they are generated from studies on the ground. Now, one of the things, if you are doing research, you should be the most highly paid person. Okay, but now politicians are most highly paid. So, but you have not said, you have not written up the report how things should be done, because you do teaching, you do services, it's 8 hours in a day. If you are doing teaching, it's over 8 hours working day. If you are doing research, it's another 8 hours maybe. And you have to be remunerated. So the way researchers are remunerated so that they can actually provide evidence for transformation, it's not there. It must start from somewhere, and it can only start from Mwimbili. So I think, Professor, we can talk more if I have not answered you to your satisfaction. Thank you.
Thank you, and I hope this time I will succeed in asking my question. Thank you very much, and I think my question goes to Dr. Swai, because I'm very much married to health systems. And let me thank you, Dr. Swai, for a good analysis of the problem we have in aging in this country, and the good analysis in terms of the problem when you compare between different countries, Tanzania being one of them. You showed Nigeria, Algeria, Sweden, and we saw how big difference was there. And actually I was moved by the fact that some of the African countries have good population population structure compared to us. And then I started wondering, what could be the reason? So when you came up with the model that had 7 steps, I thought you would take us through the model to tell us how do these countries, particularly African countries that share similar characteristics, how different are they in the different steps of that model, so that at the end of the day we can be able to inform policymakers or researchers in terms of these are the possible areas that we could pinpoint that if you look at Nigeria, Nigeria is more or less similar to us. If you look at Tanzania and Algeria and what was that other country? Ghana. Ghana has had a good structure. That if we take step one, is there any difference between these three countries? If we take step two, then by the time we finish, we should see where we went wrong. Otherwise, one will be skeptical with the model. Thank you.
So I think we'll welcome first Dr. Kelvin Reshabari to respond to the previous questions, and then Dr. Swai will come to comment on the end.
Thank you. I think that question was raised by Dr. Edward Kija, and it was partly answered by Diana, but I'm happy that you raised that question because I may give you a synopsis of why I'm happy when you raised that question. I had exactly the same question in 2014. It happened just by chance that Diana was the one who was teaching us back in Holland about the biological mechanism of aging process. And back then there were a number of models which were being implemented for generating tools. And then most of those models were based on natural sciences rather than clinical. And therefore, I was the one who approached Diana and decided that the world should think differently. And Diana supported me. I created a certain protocol, which is actually part of my doctorate right now. So straightforward to the answer, there's no approved tool as of today to characterize the differences between what you considered as calendar age vis-a-vis biological aging process, probably. However, there are a number of tools under tests. Right now, I'm dealing with a tool called glycated hemoglobin advanced glycation end product, HbAGE. And I'm trying my level best to test it in different populations of the world, because part of the reasons why we don't have a tool is the fact that the approval process it's very bureaucratic, first of all, and second, it takes a lot of time because you have to wait. Third, most of those studies are longitudinal. We can't work with those kind of tools using cross-sectional data, unfortunately. And that's part of the reason why even some of the tools which were very promising, they are not yet approved. But just to let you aware, there are several in the process. I'm also doing one of them, and it has proved very successful in the Caucasian population. Unfortunately, it has failed tremendously among African population. And the reason why we are not sure, but probably it's because of our population selection. The tool is being currently tested in Europe using Africans who are residing in America. And there are already a lot of papers trying to show us that there are a lot of epigenetic changes already, which have already happened between us in Africa vis-a-vis those friends and relatives of us who are also Africans living in America. So there are already a number of confusion that probably whatsoever we selected as a population was not reflective of Africans like us residing here in Africa because of some epigenetic changes. However, the tool was very successful among Caucasian population, extraordinarily successful. Genetic-wide association studies, the results are perfect, almost perfect. We don't know why it has failed among Africans. And also we have seen some heterogeneity among Orientals. For instance, the model, the tool currently we are using worked very nicely among Koreans who are residing in France. But in the same model, Indians residing in the same country of France, it has failed. We don't know yet what's the cause, but at least that is just to show you that it is something that is supported by longitudinal sort of series data rather than cross-section or snapshots that normally are used for approval processes. I'm not so sure if I've been able to answer your question, Kija.
From our timetable, we were supposed to finish this session at 17:20. We're having more than 15 minutes. I'm not sure if you're going to use all that time for questions. But for now, may we welcome 2 more questions. Okay, may I take the question and then he will respond? Professor Francis, you have any question? Okay, so can you take the mic?
Thank you. Good evening. My name is Amina Ahmed from Bayer University of Science and Technology. I presented a poster on revisiting the micronutrient deficiency in East Africa and the intervention program. As a professor said, we checked the intervention program, include supplementation, fortification, education program, but still the micronutrient deficiency in alarming. So one of the professors from Morocco asked me, because my background is in food science technology, so we presented about maybe we should process fruits and vegetables, which are primary cause of these micronutrients. And then he asked, like, why do we have, Tanzania is a tropical country, you have a lot of fruits and vegetables, why do you have to process? So it was a big discussion. So what I see, there is a Death Valley, and we have medical doctors, food scientists, technologists, we have a nutritionist, but the thing is, there is somewhere the knowledge, the gap for the days of the knowledge. So what I think, if all of these people come together, we need a multi-sectorial approach to solve this problem of health and nutrition, as we see they are related. So I think as FAO and WHO, they jointly work together to have some good policy and recommendation. So I think it's a time for even our research institute, our academic institutes to work with, like MUHAS, with Sokoine, with other universities, to see how we can have with a collective measure towards solving this problem. Thank you.
Yes, thank you, Maria, and thank you, Harriet, for the clarification. But my question was slightly different. My question is not related to the gut microbiome and diseases. That literature is already known. My question is from what Maria has presented. She presented very clearly the link between gut microbiome and prevention of cognitive regressions, dementia, etc. So my question is, for people who do not have any chronic diseases, they're healthy young adults, is there data which we have or in the pipeline, which if we can maintain that gut microbiome by either using probiotic or prebiotics, and then follow them up and see if we can maintain that, then these people actually will live longer? So that was my question.
Hello, thank you for your question. You mean when people have chronic diseases? In this case, obviously the use of prebiotics can be very useful in order to assicurate the production from the probiotics of molecules that can reduce, for example, the inflammation that is the main characteristic when there's a chronic disease. So this reduction of inflammation
with, for example, the molecules that reduce the action of cytokines, so promote anti-inflammation, the cause of the chronic pathology can have a reduction and a decline. Obviously, the microbiome is not the only thing that can give a total extraction or cure against the chronic pathology, but of course a sort of alleviation.
Thank you, Professor Maria. Dr. Kija, I'm not sure if you're satisfied.
Thank you.
Okay. Okay, thank you so much, Professor Maria. Okay, so if there is any other more question, there is no. Maybe we can. Okay, Professor Balanja, do you have to contribute anything on microbiota? Oh no. Okay, Dr. Kelvin.
Thank you. I have a question for Maria. Maria, I always have issues when people describe to me about the Mediterranean diet and those probiotics things, because in most cases the problem here, I think, it's about regression fallacy rather than the actual mechanism towards causation. I think my question is partly related to what Kija asked, and I'm not so sure if you have been able to correctly answer it. I have issues trying to interpret those regression coefficients that you guys get in studies and confer causal implications out of them, while we know that there are a number of other variables that are really currently likely to be operational as well. Because most of those studies which have been able to show the contribution of probiotics vis-a-vis neurodegenerative diseases, actually, if you look on those studies, the primary aim was to check whether there is an association. But nowadays, I've seen the trend is towards convincing the society that those associations we see in those studies are actually meaning causal, something which I always have issues. I don't know if you can be able to explain to us whether or not those regression coefficients that have made you to consider that the relationship is somehow causal are truly tested in real life situations, or they're still lab and sort of statistical analysis only. I'm not so sure if my question is clear to you. Maria.
Okay. Okay, if I understood, you mean what is the rate of relation between the alteration of a microbiome and neurodegenerative diseases, right?
Yes.
Okay, so from recent studies, there are correlations that indicate then that people, when manifest the symptoms of neurodegenerative diseases, have alterations in microbiome. So it's difficult to understand if there's a correlation in terms that alteration of microbiome can induce neurodegeneration, or are the neurodegeneration that induce alterations in microbiome. Of course, there is a bidirectional influence between them. I think personally that that is the neurodegeneration that induces a very strong inflammation that is more increased by the production of alterated postbiotics. So in order to reduce, as I said before, the inflammation, the correct nutrition with a lot of benefic prebiotics can reduce the inflammation that derived from the neurodegenerative diseases. But on the other end, if we can see the other phase in which microbiome induce the neurodegeneration, we can say that maybe there are a lot of damaged molecules. For example, when we eat junk food, no? That are a lot of damaged molecules that can create the condition of inflammation that is the main peculiar element of the neurodegeneration. So microbiome alterations, I mean in sense of one of factors that can contribute to neurodegeneration, but together with other kind of alterations, not alone. This is my opinion from studies until now.
Welcome Dr. Swai to respond to Professor Simba's question.
Professor, thank you very much for two professors for very penetrating question on the theme that came from the dilemmas. Actually, both of you are on the dilemmas and how do we resolve the dilemma. And the approach for me was to look for figures and facts and processes and time and people to see how we can go. For sure, one thing, if Botswana, Algeria, Ghana have done it, then we can do it. If Indonesia and Cuba did it, we can do it. So somewhere we have not made the correct decision. But I think the fundamental decision is we don't want to see, we want to see a pyramid anymore. We don't want to see so many people dying, and that is an ethical decision, because no politician will understand about stunting, about what we are talking here. We have now to translate it into a language. Now, if the ethics people or practitioners don't understand, or to a point where they can start transforming the system, never think that the political ethical equation will ever be resolved. So actually the starting point must be with people who know about medical ethics, that they have a responsibility to give the best to people. And what we have outlined here, 80% can be done at the community level. Now, have you heard about the Uturo initiative in Baradi District Council? Yeah? They were able to stop maternal mortality for 20 years. And then the Minister of Health tried to take it up, and it was in the health sector reform, but it is not in the national strategy to actually scale up Uturo initiative. But our maternal mortality here, I was in South Sudan where the maternal mortality was 1,000 per 100,000. And here, it has gone down, and now it is up. Why? Nobody can say we are the ones to say why it is. In Sweden, it is 5. At least we are supposed to go 70 to double digit. But that initiative will start from where? So I took that issue with the Minister of Health. And later on, I took it up with UNICEF. And UNICEF was upbeat, but at the end of the day, they were not interested. Okay? So UNICEF will not do anything with due respect. They are not interested in cognitive development because Why not take the head circumference? In Japan, in the other countries, they are interested in the cognitive capital of a child. That will enable the child to really integrate into digital world. We are also, poverty is no longer a problem now. The problem is digital divide to catch up, the invest everything. So, Professor, that the framework, the model that I have provided was a quick one. But we really have to know people's needs. And nobody can define and write and report about them. It starts with the really understanding people's needs and then reporting and then putting up the cycle that develops like a spiral. That process must start from a university. And the university, the first university in this country, which was here in 1961, was this one I'm talking to. And it's you people and me who would have to say, are we going pyramid or are we going skyscraper? Are we interested to see so many people dying or want? So this model, we can refine it and say, tell the politicians, we want this model. Because to transform, it takes 50 to 60 years. Castro started it. They are now like Sweden. We have not started it. Nigeria has not started it. For Nigeria to all transform, it takes, if you play around with the model, it will take 50. If we decide now, then we shall have to see results in about 30, 40 years. We are out of SDG, we shall never be there. If you read the UN nutrition, they are already out of the targets of 2025. And it is clear we are not for SDG 1, but SDG 4. So, Professor, in Rukwa, stunting is 50%. If you can simulate that is really the bottom line. If you have, in other words, for them to transform from 50, so that we can have people who can catch up with the digital world, you can give it 60 years, and you can do this mathematically. So the starting point, Prof, I would say, the model says you have to know your needs. And then you go through, at the end you have to report. If you can have the time to go through every step, you will find out why and how Ghana, Algeria, Botswana have made a difference. Because after assessment, then you go through, you'll have the report, and then compare whether it has really met people's need. But if you do if you read the evaluations and everything, there has been no national research agenda, no policy. Like now, our policy is 2007. It's out of MDGs, it's out of SDGs. And in 7 years, we are going to have, already the global health is now changing because most of us will not be able to meet SDG goals. So I think who is to say now we don't want pyramid? It is Muimbili, ethical professionals. Because when you say I, it means also you and we. And those are basics of ethics, really, that you also take care of everybody else. So I think I'm very happy for the questions from the professor. And the doctor said, really, this is a multi-sectoral thing. But I've never seen such a big. Last 3 months, a month ago, I attended a FAO, it's a FAO USAID, One Health, meeting. There was no WHO person, okay? FAO wanted USAID money. So they organized the whole meeting for veterinary science people. So there are no human health person in that meeting. I'm talking of a month ago. And FAO is the champion of One Health. USA is a champion of One Health. Okay? UNICEF is a champion of malnutrition, but they don't care about cognitive. Who is going to do it unless we do it? No one is going to change that except we, who are actually accountable and responsible for Tanzanian people. So I don't know how many people are from the Ministry of Health here. They should have been here really to listen what is happening about nutrition, about aging, everything, so that they can shape the policy. So there is a lot of fragmentation, mindset, setting, and you only need 3-4 professors to do it. It can be all of them, of course. So I think I've tried to answer your very difficult and very too difficult question, but really provoking. The thing is, do you want pyramid forever, or we want to change? And for me, at my age, that question cannot be asked many times. But for the young professionals, you can have many decades of that question. You can have a lot of those pyramids. But it's really shameful for professionals to operate under a pyramid that has not changed for 63 years. Because the initiative must come from the professionals. It is not easy, but starting the transformation process, asking the chicken to think, I think it is weird. In Europe, they are worried about dementia. Here, we have stunting of 30–50%, but we are not worried. If you are stunted from birth, what are you in life or in this world that is now going digital? That's already digital. It means 50% of population, because this is of our entire lifespan, in Rukwa, will never ever. Now, this in school results, primary school, children go to school as a rule, but they have no capacity because the brain is already damaged. You want universal primary high school when the brain is already damaged? So really the starting point is at the best, and that is for medical professionals to put up a brain that children can acquire some knowledge, and then we can develop. So thank you very much.
Thank you very much. Thank you very much, the presenters. Maybe we all are curious to know how old is Dr. Swai. How old are you, Dr. Swai?
I said I don't really care. They buried a grandmother in Kagera. She was 150 years. He's a medical doctor, retired. I, last 2 months, buried my grandmother. She was 125 years. So I think these are the stories that is given for us, but not 66. That 66 times 2 is 112. We still have another 30 or so years to go. So I think even case studies can start really. And I think the first thing is to fight for a research cake and a national research agenda.
Thank you so much. A round of applause to all the presenters, and thank you for the active audience. Our session is closed.